everyone. I'm David Chai, as well. Yeah, I'm interested in the health interoperability, whether we have some more around that. Thank you.
Good morning. I thought people would come. Good morning. Thank you very much because you're here and you are live. Kindly just wave at me so that I can see you and see me. Thank you for making it time. My name is Dr. Rachel Gidiomi, working with the Ministry of Health. I'm very passionate about genotyping, but I can't see it here. So I will take lead in human resource, the workforce. So I'm interested also for the people who work in the healthcare workforce. Thank you very much.
Good morning. Good morning again. My name is Seth Bono, working for LFT project. I'm interested in all areas, but for this session, I will be with the Health Management Information System. Thank you.
Good morning. I'm Elkana Cheria from the Ministry of Health and ICT. I'm interested in most of these things, but I will focus on digital health and ICT infrastructure.
Good morning. My name is Rachel Ojiro with Health IT, leading community health digitization. My interest is to learn more about the integration and how the various systems of the ecosystem can be linked for service delivery.
Good morning, everyone. My name is Ellen Onyeka from Ministry of Health, ICT. My focus will be on digital health infrastructure. Thank you.
Good morning, everybody. My name is Ali Hassan. I work at the Ministry of Health and Information System. My interest is in standard and interoperability.
Good morning. My name is Makoyo Bota. I work in the Ministry Directorate of Health Products and Technologies. So my directorate is my interest. Thank you.
Good morning. Good morning once again for the second time.
Morning.
Very good. My name is Dr. Wesley Oga. I work in the Ministry Division of Digital Health, and I'll be very much interested to ensure that we are ready for the HPT health products.
Good morning. Kennedy. I'm representing two, that is CHISU through JSI and Supply Health. I think for this meeting, I'll take a keen interest on HPTs.
Morning. My name is Hannah Wajiri with Health IT. Thank you.
Good morning. Give me the nice smiling. Smile that I'm giving you back. Thank you. My name is William Zioka. I work for Vital Strategies. My interest is to get quality mortality data from facilities and community. So, Muma, you will classify my interest. Where do I belong to? Thank you.
Good morning, ladies and gentlemen. Good morning. My name is Nancy Amayo. I work for MOH, Division of Health Informatics. Interested in everything, but particularly health management information systems. Thank you.
Good morning, everyone. Good morning. Okay, Kalanda is my name. Working with MOH Division of Health Informatics. Yes, I'm also interested, especially in health information, but for now, I'll be in the facility community ministry. Thank you.
Good morning. My name is Eric Maira from the WHO Kenya Country Office. I'm the focal person for digital health at WHO. My main interest basically is in the interoperability there, but that touches in most of these other items. So the other interest is basically in community health and how we can partner to develop digital systems for health. Thank you.
Good morning. Jemima Kuta here from the Directorate of Health Services at the Council of Governments. I'm interested in everything and also just looking forward to see how the information will exchange with all the systems in all the 47 governments. Sorry, county governments. Good morning, everyone. My name is Dr. Joki Fernandez from Henry Healthcare Consulting. I'm interested in all the areas, but more than anything, the e-claims and interoperability. Thank you.
Good morning, everyone. My name is Wandi Eko. I work for USA Kenya East African Office. I'm interested in interoperability or health information system.
Morning, everyone. My name is Nelson Makenga from the Association of Public Health Laboratories. My interest is in laboratory information systems, standards, and interoperability.
Good morning. Good morning. My name is Amos Laboso, HIS from the University of Nairobi, Faculty of Health Sciences. Particularly interested in standards and interoperability and shared health.
Good morning, everyone. My name is Colin Neno from Smart Applications. My interest is really on health information system. Thank you.
Good morning, everyone. My name is David Mondi. I work with the University of California, San Francisco. My interest in this subject is around the industry.
Good morning, everyone. My name is Edison Kandi, working with the University of California, San Francisco. My interest here as well is on the industry. Happy to be here. Thank you.
Good morning, everyone. I'm Magdalene from Palladium. I'll say we do understand most of the things, so we'll choose it. Thank you.
Good morning. My name is Gracie. I work with Palladium. I started my stage in most of these things, but I think I'm most interested in standards and availability and the way they are working exchange systems.
Good morning. My name is Peter Hingana, Living Goods. Interested in standards and interoperability.
Good morning. My name is Nicholas. I work for
Good morning. So my name is Moses Kibu. I'm an laboratory specialist from National Public Health, National Influenza Center. I'm interested in HTMIS, but I'm interested in other areas which are not represented there, like the genotyping and about with them. So, thank you.
Good morning. My name is Pius Cheria, Ministry of Health, ICT. My interest is on cybersecurity audit.
Good morning. My name is Nelly Nyaka. I work with the International Consulting Limited. We build health IT systems across all these thematic areas, but I have a keen interest in interoperability and standards and cybersecurity and data security.
Good morning, everyone. My name is Francis Giri from the University of Nairobi. I am interested in everything, but I'll put my focus more on terminology services. Thank you.
Good morning, everyone. Jacob Odia from Palladium. I'm interested in the standards-based data exchange and the sharing of.
Good morning, everyone. My name is Ocheng Ochola, our founder. I'm interested in the health information systems, most of the health systems governance and management. Thank you.
Yeah, good morning. This is Robert Kibet. I work with AMPA. I'm interested in standards and interoperability layers. Thank you.
Good morning, everyone. My name is Mary from Convergence Labs. I'm interested in standards and interoperability. Thank you.
Alvin Mati from Elizabeth Pleasure, the Advocate Foundation, interested in health, financing, and insurance.
Good morning. I'm Anthony Juan. I work with Palladium, and in this meeting I'll be keen on HMIS.
Morning, everyone. I'm Derek Mungamo, working with Medic. For this meeting, I'll be interested in interoperability and standards. Thank you.
Hello, everybody. My name is Wallace Bulimo. Here, I'm interested in the health information intelligence and analytics.
Good morning, everyone. My name is Kamau Mwangi. I work for KW Hospital, but also provide ICT advisory to Christian Health Association chat. And here I've been interested in HMIS and cyber security.
Good morning, everybody. My name is Gilbert Nsomo, working for the Ministry of Health, Division of Informatics. For the purpose of this meeting, I will speak my interest on shared data record. Thank you.
Good morning, everyone. My name is Selvara Chelea. I represent the Big Spine Consultancy. I'm also interested in all these areas, but in particular, health, financing, and insurance. Thank you.
Thank you. Good morning. My name is Catherine Busiri with Spine Consultancy. We will be focusing on key trade and insurance and health financing. Thank you.
Good morning. My name is Duncan White from the Kenya Medical Professionals and Council. I keep interested in almost everything, but majorly focusing on interoperability.
Good morning, everyone. My name is Shaka Kupon. I work for Omer and be focusing on health financing and insurance.
Good morning, everyone. I'm Richard Osaka. I work with History Kenya. I'll be focused more on interoperability and shared data practice.
Good morning, all. My name is Taka Wori from Elephant Healthcare. Interests, HMIS, and interoperability. Pleased to be here.
Good morning, everyone. My name is Logan Smith from Elephant Healthcare as well. Interested in all the components, but we'll be focusing on shared health record.
Good morning. I'm Thomas Mogi, Chief Information Officer at Moy Teaching and Referral Hospital. Really interested in the shared health record.
Thank you. Good morning. My name is Gloria Chole, working for the University of Nairobi. For this particular workshop, I'll be interested in the shared health record. Thank you.
Good morning, everyone. My name is Kevin Gary. I work with the University of Nairobi, and my area of interest for this workshop is the client industry. Thank you.
Good morning. Dr. Manduku Veronica. I come from Kenya. I've been teaching in critical care, but I've been interested in growth and thank you very much.
Good morning, everyone. My name is Matthew Chekiri with KP and Liverpool School of Job Community. My interest would be around health information intelligence and interoperability.
Morning, everyone. My name is Angura Nyaga with Savannah Informatics. My interest will be in health, financing, and insurance.
Good morning, everyone. My name is Thomas Uchi from Communications Authority of Kenya, specifically the Universal Service Fund. My interest is in digital infrastructure, and I think we are going to be partnering as part of the ones who are going to fund some aspects of this project. Thank you.
So good morning, everyone. Dr. Karina Mungu from USCDC. So my interest is on HMIS. Thank you.
Good morning, everyone. My name is Lucy Saliku. I work at CDC Kenya, and my interest is in HMIS.
Good
morning, everyone. I'm Madrid Gisha. I work at CTC Kenya and I support HIS. My interest is pretty much everything, but since nobody seems to be interested, I will be in the legislation, policy, and compliance team.
Good morning. I'm Oscar Biwor from the Ministry of Health Division of Informatics. I'll be taking a keen interest in HMIS, analytics, and visualization.
Good morning. My name is Samuel Kamau, working in the Ministry of Health, the Division of Digital Health. My interests are in crime registry.
Good morning, everyone. I'm Mark Thomas from Access International. I'm interested in sharing health coverage. Morning, everyone. Mutai Ruto from Access Kenya. I'm interested in shared health record, standards and interoperability.
Good morning, Ramona Courage from the Convergence Institute. My interest is with the legislation, policy, and compliance.
Good morning, George Owiso, ITEC Kenya, University of Washington. I have several interests, and but if the guys at the client registry standards and also health policy convince me, I may join one of them. And Gitai, you are coming to help client registry. That's a lot.
Good morning, everybody. My name is Francis Dairo. I'm with the Tony Blair Institute, and my interests are in cybersecurity.
Hey, good morning, everyone. My name is Andrew Tutere from the Blair Institute. I'm interested in the digital health infrastructure.
Good morning, everyone. My name is Robert Mutai from EDIC. I'm interested in the cybersecurity, data privacy, and the ICT digital infra.
Good morning, everybody. I'm William Hayes from Cape Town, William. My particular interest is really about cybersecurity privacy related to client registries and by application also shared out records.
Hello, everyone. I'm from GMP Health Systems as well, South Africa, and focus for this workshop will be on the client registry. Very happy to be in Kenya for the first time.
So, good morning. My name is Kiama William from the Association of Kenya Insurance. I will be interested in the whole system and particularly what is there for the end user. Thank you.
Mornings. Dr. Joyce Wabisha from the Ministry of Health, Policy and Research. For this particular meeting, I'll be in the legislation team.
Good morning, everyone. My name is Dr. Ryan Nyotu. I'm the Division Head for Digital Health at the Ministry of Health. And I think for this particular meeting, I have to be everywhere. But the one I haven't had even one person, maybe I will overcome, is point of care and electronic health data information systems. So that's where I'll be.
Good morning. My name is Job Ngena. I'm the Head of Division for Health Informatics in the Ministry of Health, Director of Digital Health Informatics Policy and Research. And I would also be interested in HMIS, although we've been floating around the different thematic use areas. Thank you.
Good morning, everyone. Good morning. My name is Stephen Manye. I'm here representing in terms of consulting limited, but also by extension representing Health Informatics in Africa and the Kenya Health Informatics Association. So we'll get to know what those are this week. My particular interest personally is the standard of interoperability, but I'm also supporting the director quite closely in terms of technical coordination. So we work quite closely with the group leads of each thematic area to ensure that we actually get what we need out of the groups. And at the end of this week, we get the outputs the mainstream needs so we can implement this as a country moving forward. So really nice to see everyone. Some old faces and new faces. Most welcome.
Good morning. My name is Tabitha Waweru. I work in the Ministry of Health, Division of Community Health. I'm interested in HMIS.
Hello, everyone.
My name is Karen Kanji from the Ministry of Health, ICT Division. So my areas of interest are standards and interoperability. That's including the interoperability layer as well as the strong health infrastructure. Thank you.
Good morning, everyone. My name is Jan Kiminede from Health IT Project. I'm interested in terminology services.
Good morning. The last person. Good morning. Yeah, my name is Calvin Walker from the Vesta Pediatric AIDS Foundation. Yeah, we focus on digital health infrastructure, but I'm interested in everything. Thanks.
Thank you very much, everyone. There are some guys who have just said that, yeah, please give them the mic. Which one of us needs to introduce himself? Yeah.
Good morning, everyone. My name is Good morning, colleagues. My name is Fakundo from FRT Project. I'm interested in HIV governance. Thank you.
Good morning. My name is Robert from Yeah, and in this meeting, I'll be interested in the technology services.
Good morning, everyone. My name is also Garrett from MOH. I'm interested in this workshop with you on HMIS and shared evidence. Thank you very much.
Okay, thank you very much. I think we are now ready to start. But before I call upon Dr. Abish to give us the objectives, in this room we have 100, but those who have registered using the link, where is the link? We are only 68. Kindly share the link. We are 100, however, those who have managed to register are only 63. So please, I kindly and humbly request you to be registered so that at least we can always remember you in this convergence meeting, together with your contributions. That's the only way we can remember you. So, team, I know we have our machines that we can be very busy in this meeting, but in other meetings, I kindly request that we just give some attention so that we can start this. And for this reason, I want to welcome Dr. Abishi, who will first also welcome us as the ministry, later waiting for our chief guest to come and give us opening remarks and give us objectives for the day. Welcome.
Good morning. I'm Jambo. It's a pleasure to see a lot of people that I know and some new people. To those who are visiting Kenya for the first time, karibuni sana. Make sure it's not all work and play. We do have a national park right in the city. Make sure you get to see a bit of that. For the rest of us who are in Kenya, let this also be a networking meeting so that we can get to know each other and get to know each other's strengths. So my work today is to welcome you to this meeting. As alluded to earlier by Jeremiah, my name, I am Joyce Wamishwe, and I work in the Directorate of Digital Health, Informatics, Policy and Research. Dr. Bernard Langat is our head, and together with me, we have Dr. Job Nyangena, who's actually the true host of this meeting. So Job, please stand up. They may not have been listening when you were introducing. That is Job, and he heads the Division of Health Informatics. And then we have Dr. Ryan Nyotu, the one who wants to be everywhere. Please stand. He wants to be everywhere because he heads the Division of Digital Health. So the three divisions are under the directorate, and under those three divisions, we have several units. I'm sure with time you will get to know those units, but the essence of the directorate is really to spearhead the digital transformation within the health ecosystem in this country. We are at a very good time. We are at a time when the stars all seem to have aligned. We have the highest political goodwill that has ever been seen in matters digital health. We have partners who are all willing to come together and think through and figure it out and see how we can have one comprehensive and integrated health information system. That does not mean that we are going to be saying that you need to have Elephant as the EHR or Kenya EMR as the EHR. What we really want is as many systems as possible, but these systems need to adhere to certain standards, and they need to be reading from a certain central spot so that we have a unified health information exchange to enable everyone who needs to access any information within the health ecosystem be able to access. So right from the service provision component to the commodities component to the healthcare financing component to the human resource for health component, and even when you come to look at things like research for health, we should be able to do a lot of work from that point. So this is why we're excited about this meeting. Never before have we had such a meeting. I think if we have, we've been having it as per program areas. I know we have had a similar-ish something when we were discussing HIV those days, many days ago, many years ago, to figure out how we would be having, our people living with HIV being in one particular, being within an electronic health record system. So we are really excited, we are energized, and we believe and hope that by the time you're done, at the end of the 5 days, that we will all be feeling the same as what the four of us, Dr. Langat included, are feeling and having a vision for this country. We will be discussing more about, where does all this come from and how does it tie up to. But my noble job was just to welcome you, so feel welcome. Thank you for your time. We do not take it for granted. Thank you for your brains, because we're going to be using a lot of your brains. Feel free to share. This is a sharing forum. And please bring your expertise to the fore. And what can work, say this can work. And what you think cannot work, please say it. Let us not leave this room and then we'll be hearing out there that why is the government thinking like this, and this definitely cannot work. That is why we're in this room. So if something's not going to work, Savannah, I had Savannah, informatics, please tell us Tuna, we are dreaming, okay? For the CDC, USC guys, we've been doing a lot of work in digital health regarding the programs. Please bring your expertise. And for all the others, please bring your expertise. So why are we here? Our goal, we have one goal only. We are here to co-create and commit to what? To a shared vision, a shared plan, a shared strategy. Why? So that we can accelerate attainment of universal health coverage. You know, we've been talking about UHC for the longest time. I think now if you listen to our CS, she's always saying this is the third time we're trying and we have to get it right. We have to get it right. You can't keep failing, but even failure is good because it shows progress. The problem is failing and remaining there. And then we want to see how we can do this through digital health interventions. So this is our goal, to co-create and commit to a shared vision, a plan, a strategy. And we're doing all this so that we can accelerate the attainment of UHC. And the digital health interventions is the core, is the central core on how we are going to attain this. Next. So at the end of this, and I'm ready to this to the goal, by Friday we are going to come out here with a shared digital health vision. This is very important to us because one of the things we have realized when we have been interacting with the various state and non-state actors is what we are saying is very different from what, partners are saying. It's very different from what the private sector is saying. So we want to all, if you are all like on Friday to be interviewed by journalists out there, you should all be speaking the same. Where are we going regarding digital health? And then how are we going to do that? The implementation plan. Okay? So if I am in private sector, I am in this room, I need to be asking myself, how do I build this vision? And what will be my contribution in the implementation? If I'm in healthcare financing, that should be my mind. Okay? If I have Kenya EMR only in a certain part of a facility, how will I ensure that the rest of the facility is EMRized, for lack of a better word? Or what will be my contribution? And then a shared investment and sustainability plan. So we want to speak from one page, work towards that one vision, and then any resources, any investments, we channel them to that particular plan that we have agreed on. We believe that this is going to be the game changer because we don't want to be a government that's just moving and then the rest of our partners and the rest of the key actors are wondering where is this train going. We all want to know that we are going to Mombasa and that we are going to go through Machakos, Kitwale, Voi, and reach Mombasa. And we are going to reach Mombasa at 8 p.m. and not 8 a.m. And we're going to use a train. We're not going to fly. So that's what we want. So with that, I welcome you. I request that you bring your brains, your expertise. Let's have frank conversations. And when Dr. Langat does come, he will officially open this meeting as per the way we do it in government. But meanwhile, that should not stop us from getting straight to the technical discussions that brought us here. So asanteni sana. Poleni, I'm suffering through something, but I'm usually louder, I think. Jiri, am I not usually louder? Yeah, and I would have made you guys do some, kamata, but I don't even have that strength. But tell your neighbor, please, I expect your brain and your contribution to be here. Please tell your neighbor that. Thank you. Over to you, Jeremiah.
Please can we give Dr. James a round of applause? Thank you very much for that. Dr. Joyce, I think the agenda for the day and for the week is well set. And now is for us to write history. I said in the morning that it doesn't matter you're for the patron or the ministry, we're here for the interest of Kenya and our citizens. So I want now to, before I welcome Dr. Brian, Please, I have issues about registration. The list was missing. And because it was missing, many have not responded. I humbly request you. Weirdly said, okay, fine, allow us to edit that, and by tea time, we're going to add this. So that I know one professor said I cannot be missing remaining. So sorry for that. We are going to edit, and I'll update you on that. So can you join me with a round of applause as we welcome my Dr. Rhea to give us the next presentation. Actually, you can use our videos. Use this. Okay.
Good morning, everyone. Habari ya siku kila mtu. Thank you very much, Jeremiah. Thank you very much, Joyce. Joyce. Thank you very much, everyone, for being here. It's a really big deal that we've gotten here. In the morning, we went to job and we don't know that. I think it was Dr. Yama was telling us, don't speak from the Pagana congratulations, happy birthday. But we're very happy to see each and every one of you here. I'm sure many of you would have wondered why we go through the tedious exercise in having all of us introduce ourselves and give our area of interest. For me, that is a very critical component because one of the things in this journey is for all of us to contextualize and see what the capacity in digital health actually looks like, and that it is here, and that it is local, and that we are able to do this. My name is Dr. Ryan Nofiketao. By training, I'm a health innovation consultant specializing in digital health. That means I work around the world of design. I build capacity around implementation, and I'm also pretty comfortable with technology evaluations. And today, my task in this particular presentation is to kind of start off the conversation on how we want us to be thinking as we go about the day. The type of rationale we want. We know we've all come from different backgrounds. We've all come from different experiences. The one thing that I'm sure this room is very, very cognizant of is that digital health in Kenya has not started today. It not started yesterday. We've been implementing digital health solutions in this country since I think the first one. So I think in the year around, I think it was in 2000, 2001, 2009 and 2000. So we've been doing this for a pretty long while. We've come pretty far. We're standing on the shoulders of giants, even as we come to this particular point. And even as you, so thinking, the approach we think about is going to be very important. And there are the main approaches, the main approaches that we are going to use for thinking through this, first of all, is the theory of change. Is the theory of change. We pick on theory of change as one of the guiding thought mechanisms for us to use, or thought tools for us to use, because of its purpose, outcome orientation. We're going to focus on on some of the core tenets of theory of change, focusing on the outcome as opposed to the little inputs that little inputs or segregated activities that we carry out, or focusing, and then the other tenet is system thinking, trying to see the whole picture and seeing how everything is interconnected in this whole journey. We want to focus and foster the desire for continuous learning and rapid adaptation. Sometimes the challenges we have in tech is we get very, very, very attached to things we've built, even when sometimes sometimes the need is to move in a different direction, we remain really attached to what we have, but we have to keep on always moving and engaging. The convergence approach we picked here is also based on one of the tenets of the theory of change, and this is stakeholder engagement. We want to make sure that as we discuss this problem, as we move through the phases of trying to properly define the solution, trying to come up with different ideas, iterating rapidly and testing them with the public even before we take products out. Stakeholder engagement is going to be a critical component. And the final bit is context sensitivity. Not just picking solutions and implementing them somewhere, but understanding that as you have been saying, we have 47 different counties who are going to have 47 different unique needs even as we move through this process. The second line of thought that we're going to use heavily during this workshop is going to be the concept of design thinking, and I've also touched on that. And the final one is going to be the approach that takes us from for a long time, we used to come to a solution where we start with an LMIS. We say, I want to have an LMIS, without focusing on what exactly is that, what type of digital intervention that LMIS coming to solve. So we also want to move us to the point of trying to look for the, not going around with a hammer looking for a nail, but instead starting with where the nail is and then kind of finding what is the appropriate hammer for us to use. So in beginning this, we're in a very strange state for us as a people. I don't know if you were hearing me before. Look, another thing I have to add is I have this thing called pressure speech. So sometimes I can speak very fast. If you see me going very fast, don't panic. Just tell people to slow down. It's because of excitement about the topic. So to begin by just the concept of where we are today. We're in a very strange time as human beings and even as Kenyans, especially as Kenyans. As Kenyans, we're seeing we're in a period of a rapid population boom. This population boom is being accompanied by a strange mix of urbanization. I think Kenya we're now approaching 60-40, which is one of some of the highest we've ever been in terms of the range. This is a population that, even though our average age is 19, we still have a growing, our elderly are still here with us. We have an increasing burden of non-communicable diseases that we're still battling with. I was shocked the other day when I was going through PDHS to see that malaria still accounts for around 18% of all outpatient visits and almost 20% of inpatient visits. Those are such high numbers for diseases we've been battling for a long time. When there's HIV still here, TB, some of our stats are still really bothersome. So there's still a lot of work. All the while, as we see the entry of the NCT for mental health all across the different NCT programs in a situation which is creating increased demand for health services. All this in a context where, despite us increasing the number of medical schools we have, despite us increasing the number of training institutions we have, because of the rapid population boom, the universities are not able to keep up. So we're still having a widening divide of healthcare workers to the clients who need our services. And this is here where we start talking about workforce management, where we're having brain drain or inefficient posting of healthcare workers. So we're in a situation where, with the increasing burden of disease, reduced accessibility to healthcare, we're in a point where we have increased very many challenges that, in a situation where sometimes you can say, when an innovator dies for a particular point of life. And this makes some of the attempts at which is timely, because even now the government has committed that the mandate that we're going to do is to achieve UHC. This is all people irrespective of their socioeconomic status in this country should have access to quality health services they need without incurring financial hardship. This is the clarion call that we are discussing. And to achieve UHC, there are particular pillars for service delivery. The particular pillars for service delivery. Here we have to look at the finance section. We have to look at the human resources for healthcare. We have to look at HPT security. We have to look at also some of the issues of leadership and governance. And a lot of these challenges shall be solved through the technology bit. And for a long time, like for example, if I go back to the theory of change narrative I was talking about earlier, and we imagine after we sit in our groups and we do all this work and we're going to do the individual work streams and we come together, what is it that we are hoping to achieve? What we're hoping to achieve is to implement a digital health system, a comprehensive, integrated health management information system that allows us to be able to be interconnected. This means that as soon as someone feels sick, not even as soon as someone feels sick, we start from their setting behavior. As soon as someone is in their house and they're just waiting, they should be able to have mechanisms of collecting health information, of getting information about where services are, what is important. We need to have a population that is, for us to achieve efficiency, we have to start, when we keep talking about patient-centric. We need to have, I prefer the other way. We need to have a system where the patient we're able to empower our clients through access to health information systems. And this can be in the model of chatbots or other things. I'm a bit tall at the bending is hurting very much. Yeah. So some of the challenges. Where was I? I was talking about the dream, the intended system that we're looking at. This is a system where a patient can book for consultation with a particular healthcare worker from anywhere. As soon as they walk into the facility, they're uniquely identified. They move to the entire sector, get all their services, and all this is itemized and costed as they're moving through. And then even if they go back to the community, we have mechanisms of following them up. To do this with the challenges we already have in terms of human resources is going to be incredibly difficult. We would have to train and train and train for many years. And this is where digital health comes in. And there are many definitions of digital health, but many of us being here, we're in the public health sector, so we use the WHO definition, which is just basically the utilization of ICT in healthcare in a cost-effective and secure manner to provide care. Interesting about this digital health is not a new concept. It's been used all over Africa. As of 2018, I think every single country in the continent had implemented one form of digital health implementation or the other. It's been used across various specialties for a myriad of functions. For a myriad of functions. But the conversation we want to have today is what is the place of digital health exactly? In society today, one of the things we've done as a group of healthcare workers globally is we're now in the era of evidence-based science. In this era, this means that we already know some of the interventions that are going to work. We already know some of the ways we are going to solve. Some of the challenges that we're going to discuss in a bit. So digital health is coming to serve as a catalyst for the valid health interventions. This means that if you already know, for example, we're looking at there is poor demand for services. Some of the challenges you can find is poor demand for services, failure to follow guidelines by the healthcare workers, and commodity stock out, and this is now commodity securities. So we already know how to solve some of these things. One of the ways we look at it is we look at these as challenges, but digital health interventions can come and help us to bridge these. And this is the conversation we want to go to. We want to move the conversation away from starting with the system to kind of finding the problem where it fits. Instead, to go from the other side and start with the problem. What exactly is the challenge that you're trying to solve in doing this? Have you defined that problem properly? Have you defined that problem with the end user to make sure that the problem you're solving is the one for that person? And then finally we come and then we can identify the digital health interventions. A lot of work has also been done in terms of classification. We already have a classification of digital health interventions. These are the specific things. And by digital health interventions, but I'm happy I'm in this room, so this is not new to a lot of us in the digital health team. But digital health interventions are basically what is the system doing to solve that particular challenge in the problem. We already have the version 1 and even the version 2 is still in development. So these are already documents that are available, and this work has been done for us to build on. In terms of HSS, when we look at what have we said? What have I said? If digital health can be a tool for valid health interventions, the exact place where digital health fits, for example, in the entire spectrum of healthcare, and I think the public health sector is as a core part of the health system's strengthening. I won't focus too much on that. Let's go to the challenges slide. So some of the challenges, so what are some of the challenges? And this is a model I want us to think through as we think about some of the ways we are going to look at this. Some of the challenges, for example, we talked about is the challenge to limited access to healthcare. Here, we need to really properly define that and echo out what exactly is the need. The need for that is an improved access to healthcare. And the goal there therefore then becomes having so what is the challenge? You have to first define the challenge properly. And here we're talking about the barriers to accessing healthcare services. Here we're talking about things like geographical distance, talking about lack of transportation, financial constraint, and inadequate facilities. And all this results in delayed access and poor health-seeking behavior and eventual poor outcomes at the end. And then the need then becomes the need for enhanced healthcare infrastructure, the need for improving transportation, the need for financial mechanism, which we want to go from the causality to the effect model. And then now when you're developing your goal, now your goal can be to ensure equitable access to healthcare and different things like that. For example, if we look at the challenge, if we look at the challenge for the insufficient workforce, the challenges we're having are shortages of healthcare professionals. That would be the specific challenge. It would be shortages of healthcare professionals, maldistribution of them, of their maldistribution of the healthcare workforce, and an increased workloads on the existing providers. Here then the need can then further be defined as a need for increased recruitment, a need for targeted efforts to address the maldistribution of healthcare workers, and a need for workload management. This means when we're talking about the healthcare worker registry, there's some of the challenges, some of the problems we're thinking as being behind some of the work we're currently doing. For example, and then the development goals to have a skilled and sustainable healthcare workforce, to have a skilled and sustainable healthcare workforce thereafter. When you look at the challenge, for example, of the insufficient supply chain, that is a challenge in terms of product security. One of the need then would become here, the problem would be stockouts. We see stockouts across the country of essential medicines. We see inadequate forecasting. We have trouble in accessing data to be able to do forecasting. We also have sometimes challenges in the storage mechanisms and the distribution mechanisms for some of these drugs. So then when you're thinking about what is the need, even before we come to which logistics management system was going to be implemented, we need to properly work together. And this is just a template of what I'm giving. As we sit in the group, this is part of the activities and part of the conversations that I want us to be having. So by the time we're coming to designing and deciding this is the direction we're taking, we already have a very clear need, a very clear health system challenge that we have, that we can then link to a very clear digital health intervention, and then have a proper justification for the final digital health system that is rolled out at the end. For example, if you go back to the challenge, for example, of the fragmented healthcare delivery, just to focus a bit now again on the comprehensive integrated health management information system. Here the problem is that there is a lot of repetition, a lot of duplication in terms of how activities are done. We have a lack of coordination at different levels, and this has been part of the challenge that has been seen in the sector. We already have very many systems. For example, in the country that you will find we have a supply chain commodity management tool on one side that is not able to communicate with the asset management system or the other platforms that are there. And sometimes when I present this slide doesn't quite paint a true picture of how this looks, because this is part of the challenge that we have. The exact picture looks more or less like this. Because again, as I say, we have been implementing and doing this for a long time. This is actually real data from the Kenyan society, from the Kenyan digital health ecosystem. We looked at data about digital health implementation between 2001 and 2018. If we were to, and the red and the blue are not important, but what is important is that a lot of the dots you're seeing, and a lot of the links you're seeing are collaboration and implementation of solutions. This is a model where if we try to connect each system to each system directly, we will take another, I think, 50 years to just have integration and coordination at this level. Therefore, what becomes the need then in terms of fragmentation? The need for fragmentation means we need a strengthened coordination mechanism and a referral system. We need more collaboration and partnership between the public and private sectors, and we need to focus on being patient-centered in our approach. And this is also, as I conclude, this is also one of the things. This is also one of the parts that the Ministry of Health has taken in terms of their role. The Ministry of Health has decided that in terms of this implementation, as we move forward, it's going to take a central role. It's going to play the role of what we refer to as a competitive organization. This is an organization in a particular sector, specifically in digital health, whose role is not to compete with others, but the role is to create an enabling environment, to bring together all the stakeholders in a fashion that allows us to collaborate. the role of MOH shall be to set the standards. And a lot of the discussions you'll see as we discuss about the vision afterwards, and then we go into the deep details, and then we sit in the discussion. A lot of this shall be to give the foundation of this conversation. That MOH is coming to say, this is the role we are doing. We are here to just set the standards and allow the sector to grow. If we do this, we honestly believe that we are going to create a vendor-agnostic sector, which has the potential to revolutionize everything. In conclusion, I can say, but this is why we choose that this part is important. I was reading about different countries and how they've implemented their HIE over time. And there are countries who've been trying to do this for a long time. So we are not saying this is an easy journey. For example, China has been at digital health since 1980 specifically. And they've gone through four phases. And they've digitized different levels of their system in different ways. But because they didn't begin with the information exchange, because they didn't begin with the interoperability challenges, this is where they found themselves. With a myriad of systems trying to communicate with each other, and the cost of bringing them together is so high, especially when you've gone ahead and implemented systems in different places. So as we conclude, I'll finish with this slide. How does digital health exactly come into contact with UHC? This is mostly through the 5 layers of the 5 deterministic layers of universal healthcare. Here we have the first one at the bottom is about accountability. This is about accountability with coverage. This is about being able to reach the target population and also being able to reach the full population. Which digital health interventions would help us with this? These are tools that allow us to be able to do client registration, to be able to know where all our clients are, to be able to have the unique IDs, to be able to have systems, robust systems which maintain data quality all through the data life cycle, and also being able to bring in and capture data, like for example from civil registration and vital events, and bring them into the whole process of digital health early enough. The second layer of determinants is a supply layer. And here we're looking at the availability of medicines and equipment, the availability of human resources, and accessibility to the health facilities. So here, what type of systems, for example, what type of digital health interventions would we be looking at? We'll be looking at HRH management systems, we'll be looking at client mobile apps, we'll be looking at different tools that enable us to deal with behavior change communication. Then finally, we can talk about now the demand side. How do we ensure continuous coverage and that there is contact, what is called contact coverage? And then the final one is about the quality. This is about effective coverage, and finally about financial coverage. So a lot of these solutions are the ones we are going to be discussing, and a lot of the conversations we have will fit into this mentioning in the report that we finished with. So I won't talk about the building blocks of the digital health system because I'm sure Dr. Job will cover them in the next presentation, and I will also focus on the journey. Let me finish there and say thank you and welcome to this Convergence workshop. We hope to have a really technical meeting. We hope to be able to work together. As Dr. Mamisha has told us, please, we expect your brains to be here. Come, let's join together and let's enjoy. Asante sana.
Can we give you a strong round of applause, please? Thank you very much for that. You realize that I've been in this field for almost 20 years. Technology guys, they don't evaporate, but they pass the message very well that we have done. Can you give him another round of applause? Thank you very much. Yes, can you give us the registration link, please? I think now it's updated, Steve. Yeah, so this is the registration link. Kindly now, the miss, it is still there. Let's register all of us. I want us to break for a health break. We give ourselves 25 minutes and we'll be back so that you can have the next presentation from Dr. Joe. And from there, I know from this presentation, we have a lot of questions. Just hold on them. We'll have a panel, and during that time, we'll be discussing and we'll have a Q and A question session at that time. Please just document your questions and we'll be able to address them later. Thank you. We can break for a health break, tea, and then we'll come back for the next 25 minutes. Thank you very much. Yeah, we'll be back at 11. Thank you. I know you registered in the morning, and logistics will never be enough. So because of that, we are in conversation with NAMREP, and we are happy to say that they are going to support this, the workshop, the conference package of it, and we are very much delighted for that. So there are some forms to be passed by for that. The other issue is that it's good to know that you are live on Twitter, and we are updating shortly the MOH page and the MOH Twitter page. So once it's up and running, we also request you to do something on that, make a comment on the MOH pages, at least so that we have something to remember tomorrow. So I know we have a lot of questions based on the presentations and the two which have made this morning. But before that, before lunch, we'll have a session for Q&A, and that time is when we'll be able to ask our questions. But for now, I want to welcome Dr. Joe, who will come and give us the next presentation. Can you give him a round of applause as he comes forward? Yes, and in the morning we agreed as a team, we'll all have one meeting. I know we can have several meetings within this meeting. Please, let's just concentrate with this one. And later during lunchtime or in the evening, we'll be having that. As Dr. Job comes, there's a team meeting, the team which leads the co-chairs, rapporteurs. Please don't leave early. We'll be having a meeting to debrief you about tomorrow. So if you are selected to be a co-chair or a chair or a rapporteur for tomorrow's sections, kindly note that by 4:30, 5 will need to be meeting. Thank you.
Morning. So I must say I'm quite excited today. Having been in the industry for a while, even before I joined the ministry, we've talked a lot about health information system interoperability, health information exchange. And we've had so many meetings on this, but we never seemed to make much progress. We did make progress, but it was not at the speed that we wanted. And so when we came in, we thought, let's have everyone, every stakeholder in a room somewhere, so that we can articulate our vision and have a roadmap that we plan to implement, and then we move together as a unit. And everyone will say, remember on that day, this is what we decided and this is what we're implementing. So that's why we're here today. And I want to thank you for showing up and actively participating in this. Just put this slide. So everything that we are doing in the Ministry of Health is toward the achievement of universal health coverage. And our role in the Directorate of Digital Health Policy and Research is to give the digitization angle. How does digital health or digital technology support this mission? And we are currently moving towards this primary care sort of model of implementation, where we're doing the hub and spoke model, where we have the level 4 at the top, connected to level 2 and 3 facilities. So each level 4 connected to 5, level 2 and 3, and then each level 2 and 3 connected to 6 community health units. And so this will be the unit of primary care, and it's the focus of digitization as well when it comes to digitizing the facilities. And it's going to guide how we think about digitization. So I think Dr. Ryan talked about this. Digitization is not done for digitization's sake. So we have this famous schematic by WHO where we want to do digital health in sort of a problem-led scenario or approach. So we're not having, digital health information systems that farmers looking for nails, but we're really having them as specific solutions to a given health system challenge. Whatever the health system challenge is on the left can be insufficient supply of commodities, lack of access, or to data, or loss to follow-up. Then there's a digital health intervention, which is a discrete functionality that addresses this challenge that can be delivered in any of those systems on the right. So you've seen this before, but it's really the fragmentation of health information systems in the country, and this as well. But this is the focus of this talk. And this is what we call the Kenya Digital Health Superhighway, and it's sort of a reimagination of the Kenya Health Enterprise Architecture, focusing mostly on the technology. Of course, we have the enabling environment at the bottom. We have it rests on the ICT infrastructure. And then the core digital health services. You've seen this image a lot. And the purpose of this meeting this week is to actually say, how is this actually going to work? So how will the client registry work? We need a unique ID for every client in the healthcare system. We need to track, so this unique ID will help us track them across the healthcare system so that a given healthcare record is tied to a unique ID. We need a health worker registry. We need a facility registry. So it's basically who received the care, where did they receive the care, what was done to them, who provided the care. And then we have the terminology service, of course, which helps us speak the same language. We are trying to, attain all levels of interoperability, from the technical interoperability at the bottom to process interoperability at the top, with syntactic and semantic in the middle. But it's going to be facilitated by these registries and the shared services. And then we have the electronic claims management system, where we want to define what is a claim. So what kind of data is going to be packaged in this electronic claim and pushed to the payer, and how is that going to work? What are the workflows? Of course, we have already private sector players, so how are they going to engage with the government in that aspect? Of course, we have telemedicine. We need to define what a telemedicine platform would look like, and how it provides, and how it can track and do reporting, or rather fulfill reporting requirements. Then we have supply chain management. Again, we need to track and trace all HPTs in the system. And then all this is facilitated through an interoperability layer, where now the services on the outside, so we have the point of care on the left, which could be both public and private HMISs, the electronic community health information system, the digital kiosks, and the other point of care systems. So as a government, our role is really in the middle. Our role is the core digital health services. And that, the reason, we have both private and public and faith-based participants in the room is help us define exactly what that middle means, so that you can come in and plug in from the outside in an authorized and secure way, and this will inspire innovation. So we don't want to dictate, what the point of care systems are going to be, and that's, of course we have our own issues, but you can have any digital kiosk that can fit into the telemedicine platform, and you can offer remote consultations. We have, many vendors of the HMIS in the country. We want to define a certification framework for the standards that are going to be used for EMRs or HMISs. And, you plug into the core digital health services. We have the patient portal. We can have the government one on eCitizen. But if you feel like you can develop a better patient portal that can connect to your wearable devices, that can connect to any other personal health application, then you can come in and bring your own patient portal and sell it to whoever would be interested. And then we're going to, of course, have the intelligence, business analytics, and public health reporting, and that will be for public consumption. And then the government agencies on the other side are really, most of them, really the source of truth for some of the registries in the middle here. And so this is the vision in a nutshell. And what we're saying is, as a government, we want to limit our role to the core digital health services and defining the standards for how the other plugins are going to plug in so that we can inspire innovation in the industry and move our healthcare delivery to the digital age. So this is another schematic basically showing the patient journey, but it's really the same thing. So what can the patient access? How does the end user interact with this superhighway? From home, you have the community health information systems, you have the patient portals, you have the chatbots that have been defined. Then you go to the facility, and then you're uniquely identified with the client registry. I mean, the icons there really don't mean much at present. Actually, one of the outcomes of this week is how do those things work? What are the best solutions for the client registry? What are the best solutions for the facility registry? What are the best solutions for the HMIS or the certification framework? So the health worker register and all that. So this is the PCN. The PCN is the primary care network that I presented earlier. And we're trying to imagine how it's going to fit into the HIE. So you have the static HIE, and by static here, we just mean things that are not changing on a daily basis or with each transaction. So those are the shared services, which are going to be informing the HMIS in the middle. And then on the left, we have the dynamic HIE, which is now the transactional systems, where for every visit, we'll be updating the shared health record for different patients. The claims management will be facilitating the payment for that visit, and the logistic management system will be tracking the HPTs that were consumed during that visit. So the next few slides, we're just going to touch on a few of the components that may not be clear from the schematic. So digital kiosks are part of the effort to facilitate self-employment opportunities, where this digital kiosk will be sort of portals into the telemedicine platform, and will facilitate the use, will facilitate access to licensed and authorized practitioners to provide remote care to patients. And that's going to be linked to the whole HIE. Then we have the claims management system. Again, it's a system that will allow us to enroll users, track the services they get, send claims for reimbursement, and then do some monitoring reporting. This is a rough process of how this is meant to work. By the end of the week, we hope that the thematic team working on this will have refined this further to say, how does this exactly work? And more importantly, how does it interact with existing systems? For the logistic management system, again, a rough imagining of how it's meant to work, but it's really a system that's supposed to track health product and technology from procurement to the facility and disbursed to consumption or dispensation to the patient. So the HMIS, again, we're trying to, so the HMIS will probably be the most deployed system among the point of care systems. And ideally, it will be the biggest consumer of the HIE by tracking the different unique IDs. And we're hoping, a good reference implementation will have the administrative modules and the clinical modules, and will adhere to the standards that we're going to set. Just a point of information that we're imagining at the end of this, once this is working as imagined, then the point of care is going to have, if this will be drawn to scale, then the biggest component will be the point of care systems that are just using the shared services in the middle. Of course, all this within a lens of data security. There are different models of thinking about data security. We chose this one for simplicity's sake. But there's this physical security of the actual hardware. There's the logical security that's in the firewalls, passwords, applications, and there's the regulatory, security where we have standards, SOPs, the legislation frameworks, the governance frameworks. So we have the Data Protection Act that's already been enacted. Then we have the Digital Health Bill that's currently under validation, external validation. Then we have the Health Data Governance Framework undergoing the same. And we really invite you, when you see emails inviting you to these validation sessions, please come, because we want to own this as a sector, these documents. And of course, we have the security SOPs. So that's really the vision. The hope is, at the end of this week, it's very clear where each of those components in the middle, what they stand for, how they're going to be implemented, and how we as a sector are going to benefit from them. Yeah, thanks a lot. I think the questions will be in the Q&A session. Yeah, I'll hand back over to you. Thank you.
Give it a round of applause, please. No. Well done, good job. Please, can we do better? Where are the lights? Oh, when it's dark, people can also tend to sleep. Can we have the lights a bit? The lights. Thank you, Dr. Joe. That was really a good presentation. It is clear on what we ask. It has never been clear on this. This is what we are asking. For the first time, in the second attempt in 2018, we engaged legs as government. We are happy this time around, we have everybody, all the stakeholders. So if we manage to define what is in the middle, I know the stakeholders, we have universities here, hospitals, Nairobi hospitals here, Dakar. Lord be asking, where is my EMR? If we define the highway, then it means as a country, we can communicate. So because of time, I want to welcome Dr. Wamishu to give us the next presentation. And to say this, because there is a presentation for Dr. Lana to also be doing. Dr. Wamishu is our head of Division of Policy and Research, and also the deputy head Directorate of Digital Health, Informatics, Policy and Research. Welcome.
So good morning or afternoon. Still morning. So thank you, Jeremiah. Jeremiah makes me Georgia. But as you know, at the Ministry of Health, we are all acting in all positions. So today you see me, tomorrow you see somebody else, but the work continues. Imagine. So as Jeremiah figures out where my presentation is, I will just try and help us understand our vision. Dr. Job has done an excellent job of articulating it. But I always like to say my two brothers, Job and Ryan, are medical doctors who went then ahead and learned techie language. I myself am not a techie, so I will try and explain it layman for the few laymen that are here. so that when we come to the Q&A, we want frank discussions, we want people asking the real questions, so that, as you recall, on Friday, we are not coming out of here with mixed messaging, we are coming out of here with a common message. So what we are saying is, this is the third time we're trying to figure out how to deliver universal health coverage to our people. We've done it initially. At first, we even had a special team. We were calling it what were we calling it? The GO team. Who you were in that team? The dream team. And they used to sit in a special corner in Afia House, and they were calling themselves the UNC Secretariat. They only could be seen very early in the morning or over weekends because they were working very hard to visualize how UHC will be delivered in this country. It is this team that did the pilot. You recall the days of the pilot, and they had a card. They had a card that we were issuing people, and some of the counties that were involved in the pilot were Nyeri, Isiolo, Machakos also, and what was the fourth one? Kisumu. So people were very excited, and there was this magic card that you could go then to the facility and get free services. But we know there's nothing for free. Is there something for free? I think it's free. Ladies, is there anything for free in this one? Yeah. So from there we had some assessments, and then we said somehow our previous president said, now we go large scale UHC. But by then the secretariat was disintegrating, and now we began to hear UHC is a journey. UHC, don't expect it like that. The same way we are being told about the current economic status, that there's no magic bullet to bring down the hunger. So UHC is a journey, UHC involves all of us. But the funny thing is, if you stopped people around and asked them, so what are you doing towards UHC? You got all sorts of answers. And that is when we were like, okay, we want to achieve this vision, but this vision, the people need to rethink about it. So in comes now our third attempt. And the third attempt has gone, I like to call the third attempt going back to basics. And why I love the third attempt is because it stands for what I truly believe in, that health majorly should be prevented and should be promoted. And we should not be waiting for the curative stage. We should, as much as possible, do a lot of the work at the preventive and the promotive stages, so that we have as few people getting towards where they need some curative interventions, and then, so that we are able to maximize the efficiencies. But what we've been having is a heavy curative base with a very minimal preventive promotive aspect. So we spend a lot of our money on the curative for a lot of things that could have been prevented. For a lot of things, if we had just thought about the promotive part, maybe things would be different. So we go back to the basics, and for half of the people in this room who were there in the 70s, I included, you do recall, you do recall we used to have community nurses who would come and try and see, do you have the right latrine? Are you washing the dishes and putting them on some? There was a kiwaya rack we used to put outside there. Of course, for the .coms, we don't even understand what we're talking about. But these ladies were very motherly, matronly women. I remember them. They were quite on the huge side. But they could come, and if they meet you have not been vaccinated as a baby, just know for sure that injection is coming very soon. So you find yourself in the hospital and you'll be vaccinated. And there was a lot of preventive promotive aspects. So going back to the basics. So who's our matronly lady today? It's somebody called, we've been calling CHB, then CHW, but today we are calling them community health promoters. Do not be hard talking about CHWs or CHBs. So we want to align even to the kind of wordings that we're using. So community health promoters. And Job has done an excellent job talking about the primary care networks, and the base of the primary care networks is actually the households, and the people attending to the households are the community health promoters. In that network, the apex of the network, because it is a pyramid or is it a triangle, is a level 4 facility. And within that network are various other levels of facilities. In there we have dispensaries, we have health centers, and we are not looking at them per se that they are public. We are looking at whatever you are, whether you're public, FPO, or private, you are recognized to be within that primary care network. A primary care network covers for a population of about 150,000 Kenyans. So it is in that network that we expect Kenyans to get the most as regards health. So we expect a lot of preventive, a lot of promotive, and when you do need referral, prompt referral from the community level to the level 2, 3, and 4. We expect the primary care network to be really empowered to offer a lot of the services that we need to be offering, including basic things, and I call this very basic, an ultrasound for a pregnant woman. Right now, that is not what is done. If you go to a level 2, level 3, and you are attending antenatal care and you need an ultrasound, you are referred to a level 5 or a level 4. We want, even at level 3, for there to be point of care solutions like ultrasound for pregnant women, because why should a pregnant woman go all the way to a level 5? Being pregnant is difficult, it's hard business. You don't want to keep on being made to walk around looking for a basic diagnostic service. So from there is a special healthcare fund that will be brought there. It's being called the primary healthcare funding, but I look towards Job and Ryan to give me the right word. So it is in there that a lot of the rebates and facilities will be reimbursed for services they provide, not for the people that they cover, for services that they provide. Meaning that if I come to a facility and that facility does not have that ultrasound for me, and I go to the next FPO facility, the FPO facility will be reimbursed instead of the first point of call would have been the public health facility. What will that do? It will create competition. The public health facility will begin to ask itself, what is this? Mbona hatupatiwi pesa? And then the other thing that is coming back, and that's what I'm saying, this is back to basics, is the FIF, Facility Improvement Fund. Right now, all the money that facilities make goes to the counties. Okay? But we are trying to see that facilities retain some of that money at the facility for facility use. I don't know how that, when you hear that, and you're from the counties, I don't know what that makes you feel. But it means we will not have to keep on looking towards the county government, the governor, to give you the money that you need for perhaps buying food for the inpatients. So competition will be created. We are looking forward to a time when there will be accreditation of health facilities. When you open the newspaper and you see Katholzweni dispensary is a 5-star because of the quality of services it's offering. And then nearly level 5 is a 2-star because it can be a level 5, but it is fake in terms of what it's doing. I don't want to talk about FPOs and private facilities because so I do get services from some of these facilities, and I wouldn't want to be said to be biased. So that is the one way we are going. Then the other way is we want to empower patients. So we're going to have a lot of client-facing portals. We expect clients to register themselves, clients to be able to access their medical records on phone, be able to decide that today they are going to go and see Dr. X, and for Dr. X to see them, they should be able to get into their medical records and be able to give them services. So empower the patients. Then level 5 and 6 will be true referral facilities we envision that one day we are going to even have a lot of these level 6 facilities being, true trauma, true cancer care, all that. Then we have commodities management. From delivery to the patient, we follow. It's not the first time it's been done. At least, okay, in Kenya, I don't know whether it's done yet, but we know in other countries it's been possible. Things like the COVID-19 vaccines, we could see it move from procurement all the way to the person who needs the vaccine. Then healthcare financing, including technical things like claims management that have for a long time caused a headache. So we are looking forward to seeing that being done and efficiently done. Then human resources for health, so that we are able to know who is where and who needs to be moved where to another place to be able to provide the services that are required. To do all that, we need data, and we need real-time data, so that we're able to make decisions. So that's why I said today we are in that special place where everything is aligned in terms of leadership, right from State House. Not a day goes that our president does not ask about community health promoters, because he's very keen about getting the electronic community health information system up and running. The ECHIS, or what people like to call ECHIS, I grown up calling it ECHIS, will be a key entrant to client registration. The best place to register people is at the households. Register them, know who is in the household, know who needs which services, know even who has NHIF, so that when NHIF is planning for its campaigns, they can be able to target them. So that is core. Then we have excellent leadership, obviously, at the ministry. We have partners who have already begun to align to the government vision that I've just described. And this is what we describe at such a time as this. So we have leadership. In terms of resources, I believe we have resources. It's only that the resources have not been channeled to meet that particular vision. We've been having resources where everyone is doing their things in each corner. What if we just came together and said this is where we're heading to achieve the vision that I've just tried to describe in the money, and then we channel our resources to that. And then now when it comes to policy and legislation, maybe the presentation can now come. So next. We keep on talking about, I've described this, but it's good for you to know that even in the KK manifesto, the idea of a shared health record, that I can go for a meeting in Mombasa and fall ill and then I need to seek services, that I can be able to seek services at a facility in Mombasa, that the clinician can be able to access my health record and know exactly what has been ailing me in the past and be able to manage my current condition as based on who I am health-wise. Is where we want to go. Today, if today you're taken to Machakos level 5, you fall in here, and you're unconscious, touch wood, that you're diabetic, how will the Machakos person manage to know that you're diabetic? How will they know which meds you are? For me as a doctor, the dream is I should be able to key in a few of your details and your record pops out, and I'm able to see this is the kind of patient I'm dealing with, and then manage the current condition. But we know that's not what happens. So whatever I've just thought about is the simple dream of a doctor. To be able to manage my patient well, I need to know who they are clinically. And sometimes that's not possible because that patient may come in unconscious. The other thing is the leveraging on IT. So digital transformation is, we are saying, is a critical enabler to accelerating the attainment of the index. So we sometimes talk to people and the notion we get is like, nothing has been happening in this country. A lot has been happening when you look at the health data. So this is a timeline through policy and legislative documents as regards health data. Okay, we started from 2010, but we know that right in the 70s, there was something about health. But 2010, the Constitution of Kenya comes in, and it's all about rights, the right to privacy, you know, and of course, privacy incorporates now even your health information. Then we have standards and guidelines for EMR. That was done in 2010. I see a few faces that were involved in coming up with this document. Okay, Mangas, Steve, Owiso, it was you. Yeah. But you know, we still don't have an updated version. 2010 is 13 years ago. The EMRs that have been described there are only 4, apparently. There was one called Flavor or something. Fancy. Yeah, so there are 4. And that is not what we want. Right now, the tone, what we are saying is we are going to, the Ministry of Health will, together with stakeholders, will determine these are the standards for an EHR. And when you come to Kenya, you will need to take your EHRs to these particular labs, test, and once tested, then you can go and plug in your EHR and continue working. So we need that updated, and that's one of the things that we are doing. 2012, we have the revised Public Health Act, which came into a lot of full force during the COVID-19 pandemic. Which data can you share and which data can't you share? The Public Health Act says if something is dangerous to the population, that you can keep on spreading, it's shareable. But then how much to share, you know, it's also in there. The development of the Kenya Health Policy, that's 2014 to 2030, we are still there, but we intend to have a midterm evaluation so that we align what needs to be aligned even as we proceed to Vision 2030. 2016, there is the Kenya National E-Health Policy. So we do have a national E-Health Policy. And it covers about 10 years or so. Then we have the Health Act 2017, which says specifically in a certain clause, I think 103 or 104, that e-health is a recognized mode of service delivery. So the Health Act says a lot about e-health. Then we have the Kenya Health Sector Partnership Framework. How should we work with our partners? That came just recently, I think 2018, 2019. And you can see as we move to now today, we are beginning to see the digital health bill. Yeah, it's an e-health bill. Telemedicine guidelines because of the issues that are coming up. So yes, we have been having documents that speak to health data, policy documents, legislation also. But funnily enough, all through, no one has ever been able to define what is health data. None of these documents have that simple question. What is health data? If I ask you what is health data, how will you answer? It will depend on where you're coming from. If you are in insurance, health data is the patient record and all that you need to be able to pay, reimburse, to do the rebates. If you're in KEMSA, it is these commodities. If you are in the health facility, it should be you're managing the clients. Supposing you're in the county, it will be the data that is in Kenya Health Information System, for example. So we need to define health data, okay? And that is one of the things that has been done in the digital health bill. Next. So data governance has been, it's the issue of managing data responsibly, ethically, and lawfully. As I have demonstrated, we have had documents that speak to this, but we know that health data governance is a dynamic process. What was working in 2010 will not work today. So, and then with the increasing use of technology, is increasing fears. Some of it is fears in our heads, because sometimes I ask myself, between a digital record and the registers that we have, like now the ART register in the health facilities, which are just, if you go for supervision, you just open and you can see the name, the age, this person, the HTS, HIV testing service register. Between that and the digital record, which one should we fear more? Which one do you feel like your data will be leaked? Because the reason I ask that is every time we are having consultative meetings on the digital health bill, whether it's amongst even ourselves, or we are meeting with the legal drafting team, the question is our data going to be secure? Today in this room, I would like to tell you that yes, the government will have a national, has a national data bank. It is in that national data bank that what we have been calling the shared health record is going to be stored. So that when you come to see me as your doctor, I will log in my credentials, I am registered with KPPC, and then I will be able to get your shared health record. And hopefully you will receive an OTP message that says Joyce is accessing your shared health record, and then I'll be able to see it. The shared health record will be fully encrypted until the time, that's what I understand, until the time I want to access it. How many of us in this room are ready for their shared health records to be stored by the government in the national data bank? Roho safi, tuweke mkono juu. And don't look at, I'm seeing people looking at you. Who are you looking at? It's about you. The rest, why? Why are you not? Jimmy, are you there or not there? Huh? I'm there. You're there? Because I've called you. So ukienda Aga Khan, wakimaliza kukuona ama wewe unapanga wa Nairobi Hospital. Tukimalizana hapo, your shared health record ina uploadiwa. It's all your problems there, but it should be encrypted. Nasikia. Yeah, including all the problems you're going to have in old age. Serious? So, the rest of us, what are our fears? It's data security. Will our data be secure? So, because of that, we need legislative frameworks, updated ones, policies that give people confidence so they can trust the systems. Okay? So that's part of data governance. And then we have increased awareness. Our people are becoming more and more aware to their various rights. And then we have new legal frameworks in the Data Protection Act that we need to adhere to. So, because of all that, we do have the Kenya Health Data Governance Framework. It's a draft document it's towards the end of completion. And this framework does all that. It defines health data. It provides even answers to the questions that we've been having from the counties. Counties will ask us, how long should we keep a patient file before we dispose of it? Because let's agree, we're in the center. We are in a transition. So we still have manual records, we have electronic records, we are happy. So until we move fully to electronic, we will still have to deal with the manual issues. So how long should counties keep, the facilities keep our patient file somewhere? If you go to our county health facilities, you will find some rooms are just full of files. The files have been eaten by rats, but nobody can dispose them off because there is no clear guidance. Okay? So, and then things that conform to the Data Protection Act, like for example, now today, if you're collecting my data, personal data, you're opening for me my file, you must explain to me why you're collecting that information, why you're going to keep that information. That is as per the Data Protection Act.
So you need to get consent from him. So we provided guidance as to how that consent should be sought. Next. And then we have adopted the health data governance principles, which basically are lumped into three categories: protecting people and communities from violations. From what? From violations to do with their health data. Why do we want to protect people? So that the key thing is that they trust the systems. When you trust the systems, then you are able to invest into the systems. And as an individual, my investment would be allowing my data to be in that system. Trust is built. Trust is not a one-day event. And you build trust when there's no drama. Because when the drama comes, then there's no time to build trust. True or false? So that's category number one. The other thing is to ensure that there is equity. Okay? That all counties are covered, that all people are covered, that all levels, or can I say, health conditions can be covered, that we are able to provide age disaggregated data when you need it, gender disaggregated data. And the beautiful thing is with individual level data sets, all this can be done. And then lastly is what we must always have at the back of our minds: data use. There is no need of investing into all these systems and we're not using the data. So data use is critical, and it is optimal data use that results in superior, mature systems. If people are not using the data in the systems, nobody is looking, nobody cares, then even these systems that we are bringing in will not mature. Next. Then we have, I've talked about this, the Constitution of Kenya, the right to privacy, and the privacy of their, the Kenyans have the right to have information relating to their family or private affairs, not to be unnecessarily required or revealed. Health Act, I've talked about it, is clause 1.4, where the CS is supposed to, within 3 years to effect e-legislation to operationalize the Act. Next. And then just a few more things on what the Health Act talks about regarding e-health. One of the things is in clause 105, people have been misreading this clause, that the Ministry of Health shall facilitate the establishment and maintenance of a comprehensive integrated health information system. This is not one system, like all of us from Mandera to Mombasa, tunatumia this particular EHR. No, we don't want to stifle innovation. Secondly, it is not the mandate per se of the Ministry of Health to be coming up with such softwares. Our job is to ensure that data within the health ecosystem can speak to each other and can be used to make decisions. So we need to just be very clear when we are leaving here on Friday. It is not ati gava inasema ati kama unatumia Kenya EMR hiyo inalichiwa na hii ingine inaletwa. No. Is that what we mean when we say this? I remember when when I joined NASCO a few years ago, Kimanga was in that story of the 3 words. One, what? But the last one was one MLE system. And we used to get it all wrong. And I think he used to explain it that one MLE system means that the system should all be speaking to each other. At that time, we were really talking about aggregate data. Then we have the Data Protection Act, came into law in 2019, November. And this act, there are people who hide behind this act when they don't want to give you data. You ask for KHIS data, aggregate data, dative, aggregates. Do you know how many people, men and women, have X condition? They tell you, oh, you know the Data Protection Act. Inasemanga, don't give, don't, no. Data Protection Act is about personal data, identifiable data. Okay? But it does talk a lot
about how that personal identifiable data should be handled. It does recognize health data, not just as personal health data, but as sensitive personal health data. It talks about the data subject, that is you and I, being keen. You have every right as a data subject to know why your data is being collected, where it's going to be stored, to be assured that it's going to be safe. It will not be shared with just anybody. The Data Protection Act talks about data controllers, data processors. In this room, I see more of data processors, controllers, both, okay? Are you registered? Are you registered with the Office of the Data Protection Act? Because these are some of the things that now, when we begin to enforce the CS Health, we only be dealing with people who have registered with the Office of the Data Protection Act when it comes to matters of personal data. Okay? But because of the Data Protection Act, having certain terms like data controller and data processor, one of the things that they advised us when we have been interacting with them as we drafted the digital health bill is, for Ministry of Health, you need to also have the term health data controller, health data processor, because we recognize that health data goes beyond personal data. Commodity data is health data. Data in Kenya Health Information System is health data. Data for research for health is health data. Data that comes through medical equipment, kuna ile inaitangwa exhaust. Now, one of the fun things of doing all these things that are out of my arena is getting words like exhaust data. Learning, oh, there's exhaust data. Okay. What is that data? The data that goes back to the UK if you have a Philips machine. It's to show how the equipment is working. But are we sure that is all that goes back to the UK? I'm just asking. Okay? So we have the Data Protection Act, and we love it because it came already answering some of the things that, as the Ministry of Health, we were supposed to do as per the Health Act. So now we have the Digital Health Bill. We're going to speak on the e-health bill, but I understand that digital health means bigger than e-health, and Steve Wanye will explain further. But yes, is it true, by the way, because you're the technics? Digital health, e-health, is the same. You know, to a layman like me, it's the same. Is there a difference? So one of the things I also ask is that by Friday we have agreed, is it e-health bill, is it digital health bill? It would be good to have that discussion. And in that bill, other than the normal things that are usually in a bill, we have the establishment of the, remember the comprehensive and integrated health information system that's mentioned in the Health Act. So we have that establishment. We have the establishment of the health data governance framework. Then we have a huge section on confidentiality, privacy, and security of data. It's actually the biggest section. In here, we describe things like even if you died, deceased, you're HIV positive, so you're already dead. Should your spouse be told that you are HIV positive? No, you are never disclosed. Should they be told? Should they? Yes? No? Maybe. So, we describe it there. One of our current dilemmas is a 16-year-old with a 3-year-old baby. Who should give consent for that baby's health data to be captured? The child laws currently recognize both as children. Those stories of emancipated minors where CDC and USAID hides when you're busy doing HIV testing. Emancipated minors, these are adolescents, this is where the highest new HIV infections come in. The laws don't recognize those stories. And that is one of the things the legal drafting team has been very particular with us, saying a child is a child up to 18 years. So our current dilemma is what do we do for that 16-year-old who was a 3-year-old? who gives consent for their data, not consent for services, for their data. And then digital health service delivery. So here we tackle things like medicine. You know how our images keep on being shared in various groups. Until they say, then what is the diagnosis? Doctor is in the house, you know what happens. Whatever we are doing, is it right? Should anyone provide telemedicine care? How should a telemedicine platform look like? How do you get consent when it is a phone call? Yet, the Data Protection Act says that consent must be demonstrable, that the burden of proof lies with the data controller or data processor. So it's verbal. How do you do that? Okay? So we tackle that. Then responsible, just the previous slide. Okay? Responsible legislation says that now we are going techie, we are going to have tablets, laptops, desktops everywhere. What happens when they die? So e-waste management, where we check those things. Do we recycle them? Are there parts of our computer that can be recycled and made into bits? I wonder. Tech is the knowledge only reaches hardware and software. Then health tourism, the next big thing. Yeah, how do we manage health tourism? How does your file move to India? How can you be managed when you're still in Kenya? Your biological samples, all that. That's what the bill is done. Next. So we've been having various consultative meetings. I thought of putting a few slides just for you to get what discussions we've been hearing. So sometime last year we met with the counties. For the counties at that time was data controllers and data processors. Where do counties fall? What should they do? What would be the safest way to transfer a patient file upon referral? You see, they're still thinking manual. If a client request to be forgotten, how do we go about that from a manual aspect? Because the Data Protection Act talks about you have a right as a data subject to be forgotten. And it's that work in the system. So how do you do that? But we know that your health data is important. So the only forgetting we can do is forgetting your name. But we don't want to forget your condition because we want to add it to the other aggregate numbers and do something about it. Then, how long should we retain data? I've talked about that. What are the procedures for its disposal? What is the guidance to selection of EHRs for county health facilities? This is a very good question because we are in a new, the third round. We're in what number of counties? So every time we have a new governor, they come with a new team. And the new team, one of the first things that you start hearing is let's form a committee to review which system to later. Which system are we going to bring to our facilities? The governor, the current governor starts being told, but there was another system. I don't want to hear about another system. I want a new system. That other one, I am told, they always look for weaknesses. It doesn't work here. Me, I want a system that does 1, 2, 3. True or false? Isn't that what is happening? So counties were wondering. And that time we had not even done elections. Okay, how do we choose the EHR that will work for us? So that's the question that we're asking, and we have given some guidance, the framework, but also we need to update our standards for EHRs. Next. Then we met the MOH team. Their questions were about things to do with can consent be implied? There's nothing like implied consent. Consent must be explicit. Again, the issues of what would be the role of counties as regards registration of data controllers and processors. We've given that guidance in the framework. Things to do again, right to be forgotten. And these are different teams that we are meeting, but you see the same things that keep on coming up. The issues of the data impact assessment. Then will there be need to do independent registration of data controllers? What does it mean? And then if if today, because we know Nairobi Hospital, Kijabe, they are data controllers, so I'm sure they have complied with the Office of the Data Protection Act and registered as data controllers. But does that mean that when we tell them or request that, please, we know you see some Kenyans and we would want their shared health record to be in the National Data Bank, can they begin again say, no, but me, I'm a data controller. I don't need to send data there. Okay? Well, how do we go about it? Because at the end of the day, this Kenyan one day may not be able to go back to Nairobi Hospital. Maybe their nearest facility will be a public facility. Next. Then things to do with digital health bill. So there are questions around the data governance, definition of health data and its classification, the role of MOH as a data custodian. This is a permanent, continuous question, stroke fear, stroke wonder. In the bill, we have said that the Cabinet Secretary will be the overall data custodian for all health data in Kenya. Like meaning, where does the buck stop? If tomorrow Kenyan health data is found in weeks, who will the watu wa magazeti watakuwa wakiuliza nani? They be asked AMPA, they be asked NHI, who will they ask? That is what we mean by that. But when counties hear that word data custody, they say, well, no. But we collect data at our level. Why can't we be data custodians at that level, for example? When we present to the SAGAs and NHIF and KEPSA here, data custodian, they say, what even us we want to be data custodian at that level? So how many data custodians do we have? When we go to the legal team and tell them, counties want to be data custodian at that level, NHIF wants to be data custodian at that level, then the legal team says they can only be one data custodian. So that's another, we are still trying to figure out how to deal with that. Inclusion of a resource mobilization clause that has been included. Adoption of key terms in DPA. I've talked about health data controller, health data processor. Health data versus research. We know we say a lot of research. We know there's a lot of research in this country, research for health. And a lot of this is guided by the ethical review committees. But we know there's another kind of research that doesn't happen through ethical review committees. The supervision we go for, the data quality assessments we go for, all those things where we go opening registers, then somehow kuja mtu kimanga amechomoka na publication iko JA saying how data quality has improved from X to Z. I'm using Kimanga. He has not done that. We have not caught him yet. But I am imagining that he would have, but maybe we'll find out. But all that is not covered by ethical review committees. So what happens to that kind of data? And then even the one that's covered by ethical review committee, how much of our data with its PIIs is Hugo out there? How much of it? Without a copy here, how much of it? Then things to do with telemedicine, how will this be regulated? That is why we have the telemedicine guidelines coming up. And then compliance. So the question, as we've been drafting the digital health, the question that keeps on coming up is, how will we ensure that people comply to the various things that are in the bill once it becomes law, things to do with the Data Protection Act? And there is now beginning to be a thinking that perhaps could we have a saga for digital health? It may not start today. Today it should start as the saga right now is job and trial. This is the saga here. And then over time they have realized job and trial cannot be just the saga alone. They have added Akinamumo and now they are active. Yeah? But still, even as they do that, there's a lot more they cannot be able to do. Okay? Should we have a dedicated saga that deals with things to do with digital health? Then the Ministry of Health becomes more of a coordination, more, has that more of a coordination role. So those are the insights I could have added more. But I hope in summary it gives us a status of where we are right now regarding policy, legislation, regarding leadership, regarding investments, and then where we are hoping to go. So with that, the vision that I described in layman, and then with this, do you think we are on the right path? Is there something that we are missing? And if so, what is that we are missing? Those are some of the reflections that we want. And the digital health bill is still there. We are looking for resources right now to do formal public participation. So, but we are available to still present it to as many stakeholders as possible so that we can also get that done. So happy to hear your reflections, and I hope it's getting better and better in terms of clarification. Clarity. Thank you.
Can we give another round of applause, please? Thank you very much for that presentation. I know in the house we have more questions than the answers, but if you allow me to go on another two presentations from there. I know that this gentlemen will not take a lot of time. And for this reason, I think I want to welcome Dr. John, who will give us standards in interoperability and workforce.
Thanks a lot, Mo. Thanks a lot, Dr. Joyce. She's the steady hand in our directorate, our MVP, and for the developers, that doesn't mean the minimum viable product, but the most valuable player. So, can have the presentation. So I'll take a short time. I'm still Job. Nothing has changed in my name in the past 2 hours. So my presentation now is really of the standards interoperability and workforce. We are going through the enabling environment, sort of where we are, where we're going, and how we get there is the purpose of this workshop. So before, that's really what I'm talking about today. And you know, this WHO schematic for the enabling environment, where we have the leadership and governance at the top, strategy and investment, or this on the left, then services, application, standards, and interoperability infrastructure, and then compliance and workforce on the other side. So, you know, this is a digital health forum, so I'm preaching to the choir. A lot of what I'm going to say here, you know, is known by most of you, but for the few that are new to the space, standards and interoperability are the lifeblood of health information systems, and all these efforts that we are doing now are to attain, you know, a sort of consistent definition of what these standards are to facilitate interoperability. So it is the elephant in the room, interoperability. It's what we talk about. It's become a cliche almost. But the thing about cliches I've realized is saying them too many times does not lessen their importance. So we say hard work pays. It sounds like a very common thing to say, but hard work does pay. But you know, it's said so many times that it sort of waters down the weight of that statement. You know, achieving anything really takes hard work. Again, we talk a lot about interoperability. We've talked a lot about interoperability, but it's necessary for what for the health information system that we envision, and we shouldn't let down the ball, if I'm to use the term. Next. So, for you know, the one person in the crowd that doesn't know what interoperability is, it's the ability of multiple systems and applications to communicate with one another by accessing, exchanging, and maintaining and making use of the data in a standardized and systematic way. And it's not the same as integration. So integration is when you're trying to hard code how two systems are going to talk with each other. But interoperability is a way for multiple applications to exchange information without actually changing the actual application, and often through the aid of standards, middleware, such as the HIE that we're trying to do here. So we're looking towards interoperability and not really integration. There's levels to interoperability, and that's why it's like an onion. It's a layered discussion. We have technical interoperability at the bottom. How does the actual information exchange happen? Can I send information from here to there? If we to use an analogy, the fact that I'm talking right now and you're listening and you can hear, there is exchange of data from my vocal cords to your ear mechanisms. So that's the technical interoperability. But if I was speaking French, then there is technical interoperability, but there's no, wait, no, that's not, so that's semantic. So syntactic is really the structure, so that I'm talking in sentences and you can perceive that as a sentence. So syntactic is the structure of the message that is being exchanged, and that if that message is, that structure is understood on the other side, that's syntactic interoperability. Semantic interoperability is the meaning is maintained. So yeah, that's where the French bit comes in. I'm speaking English and you understand English, so there's semantic interoperability in how I'm communicating to you. And then there's process interoperability. Now, once you have the information, can you do more? Can you facilitate a few processes on your side that were triggered from my side? So we've done patching along these levels. We don't have full any of these interoperabilities, and our goal is to have, so each of these levels layers with the other. So you can't have some syntactic interoperability without technical interoperability. You can't have semantic interoperability without the two below, and you can't have the process interoperability without the three below. So it's a dependent system. This is where we are. Again, you're going to get tired of this fragmented slide, but it's part of the job. So what are standards? They really make interoperability easier and more efficient, and it's really consensus-based. How will I define it without a slide? Agreed upon way of doing things. Yeah. So it allows a set of rules that allows information to be shared in a consistent manner across any digital application, approved and published by an authoritative organization, and they're key to how interoperability works. So it's an agreed upon way of how we're going to go about this interoperability thing. How do we, refer to things in the healthcare enterprise? Those are the terminologies. How are we going to structure the messages? Those are the document standard. How are we going to actually exchange the information? That's the APIs or the FIRE resources. So all these are standards, and we need to define them this week, or start the process of defining them. So the types of standards, I wouldn't really go into the details of this, but we have terminology standards, messaging standards, identity standards, document standards, and they're done by different organizations. So the idea is, we need to pick industry globally recognized standards that, over the past few years, we sort of coalesced around different specific standards for different things, and those are the ones we would like to take a look at this week. So we have standards that semantic standards that convey meaning, and we have syntactic standards that convey the grammar or the structure of what is being shared. So where we have inconsistent definition of standards, we have inconsistent application of standards, and we have sort of inadequate technical capacity on digital health standards. We don't have enough terminologists, we don't have enough people trained on these newer standards, and we need to capacity build on these standards even as we define them. So next is workforce, another important bit, because everything we're talking about here has to be done through human resources. And the current status is we have an increasingly digitally empowered population who can consume digital interventions, but we have few trained digital health professionals. That's you're probably everyone in digital health in the country right now in this room. So that's for a country of 50 million people, that's not much. We have inadequately skilled in-service practitioners, and then digital health moves faster than we can update our curricula for pre-service cadres. So this is the state of the lay of the land, and where we want to go is we want to update the pre-service curricula to include digital literacy, digital health. We have to upskill in-service practitioners. At the back there, you can see we have the Ministry of Health Virtual Academy, where we're hosting trainings, and we want to add digital health training as part of that virtual academy, and to improve digital literacy among the population. Even as this is increasing, there's still a lot of digital health interventions that can't be used because the target audience is really not digitally empowered. So putting it all together, we want to do a consensus-based approach, and that's why we have this meeting, where all stakeholders are part of this push towards HI, our working HIE for interoperability, to define these standards and have a roadmap for implementation, and to boost the digital health skills, both among the human resources for health and the population. Thank you. That's,
Please, let's give him another round of applause. Thank you, Dr. Joe, for the great presentation. Now we are almost there, and before we go to the Q&A session, I want to welcome Dr. Ryan, who will talk about service application and infrastructure. Welcome.
Very much to our MC, Momo. I'll try and be as succinct as Joe, just so that we can have some time for questions. I think we'll be speaking for quite some time. So, I used to speak about now from the building block. From the building block component, when we speak about the services, applications, and infrastructure layer as part of the enabling environment. Here, services and applications, we're speaking about now some of the tools that are going to be coming to target to some of the tools that are going to benefit from the utilization of the HIE. And this is actually one of the places where we need a bit more coordination. It is something which I think is under, I can't see Dr. Wesley, but Dr. Wesley, Dr. Wesley's unit is going to be in charge of this area of thematic management of the different solutions. Because in Kenya today, it's very difficult for someone who is not actively engaged in a project to know what is happening in our part of the country. And this is a challenge in terms of also the innovation, because when another organization is even doing their funding around or looking for finances, they never think to ask, maybe Joe, what system does he know which can come and plug in? So we are keen on developing this, and also part of this workshop we are planned to talk about the digital health atlas and see how we can populate it, because in this room we have quite a few of the main implementers of different solutions. So when we came into the ministry, one of the things, don't worry about the slides, they're just going to one slide. I'm going to speak through this one. So don't focus too much on the slides. I'm basically going to talk about a few of the systems that are run and maintained by MOH, and then some of the ones which are, and then also I'll mention a bit about infrastructure. Infrastructure is something you can cover in this conversation here. Maybe I can talk about it at the city center, and then I'll finish with some of the services that I'm able to offer. So in terms of application, at the moment, a lot of my time is spent with eChisWork, which is an electronic community health information system. This is a system whose user division is a community health division.
And it's an electronic health information system which is meant to allow us to be able to, this is the one the CHPs are using, moving house to house. This is a very interesting system that has been developed in one of those really interesting models, because it's been developed through stakeholder engagement with the private partners working in the community health area. All of them agreed to come and work together, and they received a lot of support from Rwanda, AMREF, Living Goods, and the people who are currently running the development at the moment is Medic Mobile. The system is hosted within our data center. So that's the format I'm going to take for all of the systems. So I won't go into detail, I just mention them just for us to know, because sometimes it's nice to know, like, I guess, despite being in the sector, I didn't know we had like so many systems sometimes running and they're out there and they're available. Well, some of the other one that is interesting is the ER system. This is the emergency alert and reporting system. Whose user division is now the Division of Disease Surveillance. The interesting thing about this system is that it's completed and it's currently in use, and it allows us to be able to get crucial data for decision making and epidemic control measures. It is used at emergency at the EOC to capture, report, and view emerging epidemics across the country. Then there's also the viral load and early infant diagnosis system. This one is a NASCOP-owned system. NASCOP is the user division who run the system. And it's also developed with the help through USAID. Other systems which are there, we have the Darura, which is an event-based surveillance system, which allows us to be able to capture EBS data, and this one was completed and started to be utilized in the 2020. TIBU is also there. TIBU is run by the TB program. And part of this is just to show some of the silos and some of the systems that are running, and they're really mature systems, so we do have capacity to run some of this. We do have a lot of capacity to run these systems, even within MOH and the partner ecosystem. So TIBU was implemented by a TB program, and its purpose is basically diagnosis, case management, commodity management, and financial management when it pertains to the TB program. And I know even recently at the moment, Malaria is rolling out their own system. It's currently developed, it's been piloted in Bogoma. So this is a system which is also going to come and join the cash or systems that we have. We also have the laboratory information management system, which is an interesting conversation because it's one of the components of the HMIS group that are going to be discussing setting requirements and understanding where we are. But the National Public Health Labs have a system as per our records from the current analysis we've been doing, that is running and is functional. And the user division is an NPHL. The other one now we can go to we have the KHIS, Kenya's our private joint of the HIS team, one of the largest global deployments of DHIS. So that one is still running. I won't mention too much about it. The other systems are just mentioned and just save time. We also have the Kenya Health Master Street List. These are web-based applications that enable us to list and identify where all the facilities are. And this is the one we'll be upgrading to go and see how to convert it into the full registry. Dr. Job has mentioned the Virtual Academy, which is also a web-based e-learning tool that is currently available and is supported by GOK and hosted by HIT. There are also other platforms that are there that are of utility for us. We have the data analytics platform. We have the MOH service desk. We have the IRIS system. IRIS is important because this is our web-based health workforce information system. And we combine it with one more is how we want to see how to go about building a healthcare registry from part of this system. We have KHRO, which is the Kenya Health and Research Observatory, which is meant to is a portal that is meant to improve availability of research. As Dr. Joyce was mentioning, you don't know where research is. This is a tool which is supposed to be there. And interestingly, the user division of this is your division. Then we have the Chanjo system, which is there. This is the one which we use for the vaccination for the registered citizen. And I think initially it was being used for vaccination and is currently being upgraded. And this will also be one of our first model instances for developing a fully fire-enabled system. Each is doesn't fit into it. But these are the early ones where we are looking at how to move it completely, make it completely able to utilize fire resources. Then the next one is regional electronic cargo and driver tracking system. This one is owned by the user division, is a port health division. And it provides a surveillance system to monitor long distance trackers and enables us to collect their data. This one was important during COVID-19 especially. Then The other systems that are there that have been developed is a recent AFIA-KE. AFIA-KE, the system who we just started the first round of external validation of this system because it's an end-to-end. It's supposed to be an end-to-end health management information system, which has 3+ modules and is able to link to other services. Okay, so that's it in terms of the applications. Those are some of the applications we have, but those are very few applications. I'm sure once we finish and we're able to complete the DH, the digital health atlas, but I'm sure we'll be able to find very, very many other solutions that we're able to use. In terms of infrastructure is a unit under the MOMO. MOMO is a unit for infrastructure, and it has two main components. We have the HIE, and then we have the physical infrastructure bit. In terms of infrastructure, this is a conversation which is of interest. I'd be very interested to see what the group discusses. Because at the moment we do have physical infrastructure. I think at MOH we have around three data centers, the largest of them being a very robust tier 2, that is only being utilized about 10%. So we have to see how to come and mix it. Part of the discussion will be we want to have in terms of infrastructure is how do we join them, how do we utilize these resources? Because when we have discussions with ICTA and with the ICT authority, as soon as they come to validate your data center, they will use it even for other purposes other than health. Because the model is to have one system that is running across the country to try and save some of these resources when it comes to this. So the team were able to come and do some of the assessments. We did an assessment of the current data center, and that's what I don't present, but I just mentioned a few bits here and there. So we have a very good data center. It's a tier 2. It has good security in terms of physical security. No one is not able to access it. We have sufficient server space and racking, network racking. The cablings are well organized, and the system has cooling system with event redundancies for backup. The same applies for power and fire detection. In terms of scalability, there's a lot of room for being able to scale our current data center. So this is something which, as we continue to use it, we'll be able to grow and scale it. Some of the main challenges came in terms of network connectivity. We have to find ways to make this more robust, and this is work as currently ongoing. We are currently actually about to conclude some of these centers. Let me see which ones I mentioned, which ones I won't. So in terms of computing resources, as I said, the center is currently being underutilized with only 10% CPU usage, and I think memory is being used at around 15%. So this means there's a lot of room to migrate and bring some of the systems on board as soon as we're able to sort out some of the infrastructure and access SOP issues. The server also allows us to be able to do remote. It provides secure remote access as it is. And again, as I said, the challenge we're having currently is staffing. Those are the ones I want to speak about. I didn't want to spend more time. I want to go into a situation where now we start hearing the rest of the participants' voices, and we now start to have debates. The first part of the presentation was just really as a general overview and just to bring you into the conversations we've been having day in, day out. I'm sure we're all very eager to continue, so I'll give this to Momo to see how to take us to the next session. I think we still have some time before we can do lunch. I don't know how many questions we're going to do for this next session.
Thank you very much, Dr. Brian. Can we give him a round of applause, please? Now, I request for the lights. And, as the lights come, we are so far over 130 in the room, and only 98 have managed to register. So our registration link will be here, and I humbly request you that we all register. Let me say this: we don't have a database of these great people who are still here today. When the ministry wants to get some assistance from some of the areas of information, you may not know where to go. But with this, will help us to be able to at least reach you at his and work with you in this partnership. Again, a lot of questions have arisen about artificial intelligence in the options we had for record sections tomorrow. And I know that's where the world is, and that's where the world is going. So we'll find a way of providing it. Initially, we had only thought of CHEL, but it's coming up that, the team, but it's also coming up that it's important to think about the AI. So you have not to worry about the team, which is interested with the AI, and I know it will be a great opportunity for you to share with us, because the artificial intelligence is also part of the HIE, so that will be happening. The other issue is about, we are very many, but when people see us out there, they only see empty benches. I'll humbly request, when we break for lunch and come back, just please ask for that at least we don't seem to be. We are talking about you are working, but you can only see Dr. Ryan, you can see only Dr. Job, and see what the guys will do. So at this point, I want to welcome the three presenters who have done some great jobs this morning. So to come and be seated here, so that I can tell you what is next, Dr. Joyce, Dr. Ryan, Dr. Joe. This podium is yours for now. I'll give you the next direction after that. And I also want to request Bernard, where is Grace and Martin. We move around with these mics. We'll take the first round of questions around, and I can request you always direct your question to the presenter so that they can also enhance you. So the guys I'm mentioning, come and take the mic. I'm waiting for Dr. Joyce, Dr. Joe, and Dr. Ryan. Please be seated. You can be seated on my left side so that also you see you. And I'll bring this other one down. So please, this is our time. Remember, for you to be here, we asked, we look at the data very well. We asked the organization to give us the best. Please, Dr. Amishi, I can request to sit in between the two gentlemen so that you can also, So we want to take the first round of questions, then from there I'll tell you what to do. Yeah, we start here.
Okay, thank you so much. I really appreciate the Directorate for putting together this consultative meeting. The objectives are aligned, and we all agree that they're going to solve a need that is felt, and especially at the county level. I know counties are the ones that have the most systems in place that will require to be interoperate. And my question is to, I think, Dr. Joyce. And since counties are at different stages and capacity in terms of taking up this digital space, are we looking into doing a scoping assessment for the counties to understand where they are and whether they are even ready to take up this kind of technology or deploy this kind of technology? And also, what support could there be for some of those counties that are not able, in terms of even infrastructure, internet, computers, and all this technology that goes with digitization? Thank you.
We are taking 5 questions. Yeah, please.
So my question goes to relates to the presentation done by Dr. Newton, and it's around the components of digital health, which is big data and machine learning. As looking at one of the slides that is in one of our leaflets here, which has the Kenya Digital Health Super Highway. And if we were to categorize that component, big data and machine learning, it would be on top of the interoperability layer, just before the data get visualized or it's accessed by other people. And so my question really is, how do we, what are the regulations that are there in terms of utilizing the pool of data that we have already integrated, and this relates to both the structured and unstructured data. This is for bioinformaticians and probably data scientists who partly do the visualization part, but there's a chunk work that goes into the data that is already put together before they get to visualization. And so really, how do we maximize the data that we have to inform care and the decisions that we make? And that also relates to the other presentation done by the presentation of the legal framework, which has a restriction around how much can we do with the identifiable data. I know there is a part of how we need to anonymize data before we share to other people to analyze, for instance. And then there is the aspect of focusing on person-centric data, which require maybe linking together, bringing together data that relates to an individual. And if we want to apply machine learning and in that context, then what are the regulations around that? And the other question is on consenting. To what extent can we consent for personal identifiable data, especially when we have secondary data in use? And lastly, relates to how can we the flexibility on moving from one session to the other, considering most of the thematic areas are somehow related. Thank you.
So thank you very much for very good presentations. My question goes to Dr. Joyce. You mentioned something around the facility group that's coming back. And I think this relates to legislation, especially by the counties. So how do we see the people in this room and also the national level participating and ensuring that all counties are able to enable this so that it will be used in the implementation of the vision of the national level?
My question is to Dr. Job about that box that says National Health Analytics and Intelligence. Now, if you look at the bigger box that talks about health interoperability services, it's been broken down into the individual components because it's a fairly complex undertaking from an implementation point of view. So my question is, would we want to do something similar for the sort of tail end of the process, the data use component, where we talk about what it takes to put this data together once we receive it from the different systems in terms of data lakes or warehouse technology, or how we basically make these available for analysis in a more streamlined fashion. Thank you.
Oh, okay. So I have a question for both Dr. Duke and Dr. Joyce. First to say big thank you for a very impressive presentation. I'm very sure for sure they start. My question is more on the operationalization of the superhighway itself, especially for the venture will be private sector, will be private players, public, with all those different points of contact. In terms of its mode of operation, well, you will have defined the standards very well. My question more is, will there be some form of enforcement? I know it is a question of a carrot and stick in this case, and we also want to have all the players coming on board without causing so much friction around. How do we see that to be the most practical way of operationalizing without causing too much friction in the chain itself? Is it part of the evening, or will there be other ways of it?
My question is, the proposition for implementation, I think we'll appreciate that we'll be able to operate in a hybrid mode for quite some time before all the facilities are automated. So I don't know what provision is there to ensure that when I visit a facility that's purely paper-based, and I visit another one that is automated and pushing the data into the repository, how that will work out to ensure that again, we don't get ourselves in a situation where data is part in paper, there is part is automated, because there's no restriction. I can be able to visit any facility wherever I am and be able to ensure that people to get that data there. The other bit is about
the most difficult bit of automation, and that is change management. Because I say technology has got, the system has got the people aspect, the technology and the business process are the most difficult of all. Any person who's implemented in the system can be able to tell you is the people aspect, and I think it deals with the change management. I don't know how that will pan out. I know this is one of the initiatives, but I think the people on the ground who implement, I think we need to be thought through how change management will be done to ensure success. Thank you.
Okay, we can do the first 5, then we'll come up with another round.
So thank you for your questions. In there, I hear also some unspoken questions. So I'll also be bringing that out so that this can be a discussion. It's not that we're sitting here that we have all the answers. I think the answers are in this room, not necessarily amongst us today, but in this room, we come up with the answers. So I'll answer a few. Jemima talked about the county. Counties are at different spaces. So I will get to the school with you. So for that particular question, Dr. Ryan is actually better to handle because of the technology front guide. But what I would also want to say, when I was presenting, I did allude to the fact that there has been resources. Even today, there are resources. And you recall one of the slides on the insights from the counties were asking, how do we know which HR to bring in on board? So the question is, and that's where we are useful. If we say that we want to digitize our health ecosystem, should we come out from this room by this date? We should have digitized. Is that pushing it, or should we allow for a more laissez-faire kind of approach where counties that want to digitize, like Nairobi County, Murang'a County, they're already on that pathway. We allow them to move. The ones that don't even need, they can come on board in 2030. We want to go that way, or do we want to come out of this room saying the next 1.5 years, NDC are going to digitize health ecosystem? And why do I ask that? Because of the question that has been asked about, there will be some time for transition. So in the digital health, we are going to have a transition clause section to cover that time. But how long should that take? Should it be 2 years, 1 year, 6 months, or 5 years? I believe that's something that we need to discuss as stakeholders so that we can come to a very clear way ahead. But for the technical things, I'm sure I am to talk to it. When it comes to big data, machine learning, the only thing that we're guided in the Data Protection Act is, yes, you can use it, but you don't use it properly. Don't use machine learning to use it properly. For example, we are looking at a data set of Kisumu, the western side, and then you say everyone in Kisumu has HIV. That's not fine. Or all men for this particular place are circumcised or are circumcised. That's not fine. We're already using machine learning, using our HIV data sets to determine who's likely to get treatment. So that we begin to do something about it long before they get treatment. Now that's different. That is improving service and improving quality of care. If you come for HIV tests, and as per the questions you are asked, high risk, and the test turns negative, then that's a person to go telling them more about PrEP and see whether they can. That is what we're really doing with the HIV intercepts. So it can be done, it is possible, and we look forward to doing this even more, moving from a descriptive analysis point of view. But what the Data Protection Act says is the provided in the digital health field and the data governance framework provided now how that should be done. Maybe a lot of the identifiable data, but if you need identifiable data, then and it's from the big data sets that are within the National Health Data Bank, then that's what the CS has to show. And that's not to stop, but just because of the overall custodian. Now, starting to expose identifiable data, we do need some checks and balances. So that is what is happening now, but it would be good to hear how else you think that should be done. Under the operation, the FIF, Facility Improvement Fund, that is coming through a bill. Wesley, you want to talk about it? Wesley can talk about it. Wesley, you can talk about the FIF. As the mic goes to Wesley, let me just move on to operationalization of the superhighway. Stakeholder consultation. Obviously, the government will not be doing things in, a Capone. The stakeholder consultation, it doesn't start today. It's been ongoing, but today we now have, all of us together in one room, and it doesn't stop today. We are the ones who are going to really give, the milestones, the flag posts, how we want to operationalize this vision. So the reason for this meeting was to share the vision, so that you buy into the vision, then we begin to have discussions of how we want to implement this. But again, Job and Ryan will speak to that. Change management, Ryan will speak to that. That's his favorite topic. But we've already started doing that. One of the things that we are really voicing, when we do have the many consultative meetings, is on the issue of HRIOs, Health Records Information Officers. They are going, with this whole vision, they are going to be data managers. They are going to be the primary promoters of data use at all the levels. So we are moving health record information officers from a point where they were the ones keying in the data, because that's what happens today at the sub-county level or at the health facility level, keying in into the KHIS. But more of, they will be ensuring that quality of data is there. Okay, but what does that mean when we are now talking to the KFTCs of today, or to the various pre-university, what is it called? Pre-service. What does that mean? Does it mean that KFTC needs to rethink how they are offering that particular curriculum? So those are the discussions. But everyone, this is a win-win, with nobody being left behind. And change management starts actually with the people in this room. It starts with us, not out there, us. So you have to ask yourself, me now, in this whole vision, what do I need to do to contribute to this vision? And I think I talked about that at the start. So
let me just give an up, because now we've got some more activity that the FIF that was asked for. I think what we've noted is a number of counties have been able to do their county assembly past the FIF bill. Although what has been the challenging, what we got from the legal of the ministry, is that some counties maybe were saying 15% of what is collected remains. The percentage, I think those of you who work long for the ministry are aware, we still have a percentage to protect prevention of another one being used as source. So what we are currently doing, especially with the legal team within the ministry, is the harmonization, so that all counties can be able to agree what is the percentage we want to remain, either at the facility for purposes of facility improvement, and secondly, how many can go to there's the MOH part that does the preventive. I think most of you are familiar. They used to be called MOPs back in the days. So there's that percentage they agree. Otherwise, the bill has been worked on. We've got support from THS and the legal part is actually done. And the most important thing that you need to be aware that there's a lot of blessings and support from the Office of the Presidency, and most governors have actually put it. So the FIF bill is actually come, and I don't want to say we have numbers, but you can ensure we pass the bill. Thank you.
Thanks a lot, Wes and Dr. Bishop. So I'll answer some of the other questions. One was on the National Health Analytics and Intelligence component. And, you know, if we're going to, or if we thought about how we are going to architect how these different data sources are coming in and how we're going to collect that to do the analytics and the machine learning and all that. So yes, this is being thought about. It has not been completed, but as Ryan showed, and as the different components we are putting together, we're still trying to see how all these systems fit together, how they're going to, as the secure the data, how we're going to collect it, how we're going to clean it, and do the whole ETL process to do the analytics. Some of this has been done in sort of answer a simple way for the descriptive work that's currently going on, the Kenya Health Research Observatory and the DSL at the University of Nairobi. So we'll just build on what they've done as we now receive client level data. Then the work on operationalization of the superhighway. So to add to what Dr. Misha said, we're still, she brought up the issue of the semi-autonomous government agency that may be needed, because to enforce this, we really don't have capacity of ministry, and we are looking at what framework we can use in the short term and the long term to do the enforcement, the compliance, and the operationalization of this superhighway. So it will probably be, either a new unit at the ministry, something semi-autonomous, or something at ICTA. It's still not clear yet, but it is definitely have to be a vehicle that is purpose-built to manage this entity. I think the rest.
Thank you very much. Okay. So I'll begin with the counties conversation from the COG team. Counties are important. Counties will represent a lot of our implementation capacity. And the one thing I think with counties is, I think at least the one view I know I carry and I'm sure which share with me is we really believe in the county's capacity, because this is where service delivery is, and digitization does not come to create new systems. Digitization comes to map over current existing system. And the demand for digital tools at county level is demonstrable. Like this thing is just not published, but I'm sure if you go to any county in the country, in every new government has procurement of a new HMI system. So there is demand for these systems at that particular level. The challenge has been how have we organized ourselves. And some of this are structural organization. And I think we'll work with COG, because the challenge I would ask is which if every single governance manifesto at the county level, all of them talked about digitization, but how many of them have permanent digital health staff currently working? All that burden has been placed on the HRIOs and ICT support staff at different facilities. These are different conversations we can come and discuss. And if organized properly, I'm sure we already have enough. We've had discussions with ICTA. The ICTA promised to give us ICT support all the way down to sub-county, level. Diana is one who's in charge of the change management unit within the digital health division. So we'll do a lot of this work with her, where we'll come and see how do we, and we've already had even communications through COG down to the counties, especially as rollout reaches, to have counties start forming the teams that are going to be doing implementation. And the structure we're looking at there is obviously we're going to have the HRIOs, we're going to have the ICT officers. It's important to always involve the HPT teams because of the delivery of devices and different management of commodities. Everyone is going to start forming the HIS teams. Then we also have tools that can help us get adoption. Technology can be used as adoption tools for technology. So some of the tools we have, for example, is MFL. the master facility list. The master facility list, we're working in concert with the HRIOs at ground level. Once we've been able to organize them, we'll be able to ask them to go and update on their level a lot of data about what is happening in the facility. This will allow us to do massive surveys in terms of capacity and readiness without having to go to the extra cost of going to do the ground surveys physically and visiting. So there are models we are looking at, and from those models we'll be able now to come and see how to better support this. But for counties, I'm excited to see how we work with counties to get them to adopt this. And this is also linked to the question from I think to Dr. Mwani from Fukijan about change management. Change management is going to be the one of the most difficult things. Even as we talk about this, even if you ask us about timelines, we say setting up the systems will take a short time. Implementing them and having them properly used is what will be the main bane of the work we do. A lot of this has been answered well. Is about early engagement with the users. We are not going to adopt the model that has been there previously, of where we sit and develop, then we have something, we go out and take it. As soon as we have an MVP, a minimum acceptable product, we'll be doing it. We will have a lot of prototyping, we'll have a lot of engagement with counties, we'll have a lot of engagement with doctor groups. In this group, one of the groups that are missing is that we don't have KMA is supposed to be here to be representing the doctor groups, we're supposed to have some of the regulators, but we don't have the patient community groups here. These are some of the people we bring on board into the conversation to try and see how to bring them on board further. We're also going to really, in doing this, is going to allow us to improve our incentive design. What is in it for the end user to come and use this particular system? And some of these things, for example, are not new. They've been done in different parts of the world. When the UK wanted to digitize, they linked it to being paid. You could not access the insurance services. You could not go and access the other services if you are not using the HMI systems. This caused people to do it. You saw with Kenya, we were told to register ETs, you're a VAT company. People delayed. As soon as the deadline came, their numbers went up in terms of adoption. So there are models which are available for us to be able to do change management, but the main one will be early engagement with the end user, bringing them into the conversation and using design principles in terms of how we roll out a lot of this. However, this doesn't mean that we won't go into the hybrid system. It will be a phased system, and we want to start with demonstration of value first to them so that they can come and adopt. Because at the moment the challenge we're going to have is actually with the level 2 and level 3 facilities more than we are with the level 4 and level 5 facilities, especially in terms of connectivity and connectivity and electrification of some of these facilities. I know Joe will talk about the machine learning and the data models. This is your pet topic, but for AI, we are excited about AI. We are not afraid of, I can say we are not afraid of AI. AI is already in use a lot. The conversation, the future also of being Kenya is that in Kenya we call a meeting and we have all this knowledge coming to us. This means that best practices are going to come to us much faster. The WHO is already actively developing guidelines about how to engage on some of this conversation. This is some of the discussions we're having. And just because we started talking about the HIE, is because within the HIE is the one we do first. It doesn't mean that AI is not something which is really high up in the priority of how we do some of these things. So even as we discuss some components, for example, as we discuss a shared health record, one of the components there is we have to start designing. We don't want to design a data model now that we have to change data to adopt AI. We want to imagine what is needed later for that as we design now and make sure that whatever we roll out is already adaptable and already usable with AI. But I'll ask John to mention maybe one more about that. The question about enforcement has been answered well by Dr. Job, but I will repeat. For enforcement, before we get the saga, we have to find a framework for it. We have a few ideas that are bouncing around, but we shall engage more, and we shall come with ideas, and we shall see what is there. But then also what I'll also urge the group is, let's all take the approach of evidence-based implementation of digital health. We have a lot of case studies, we have a lot of this work which has been done elsewhere. This is some of the inputs we really appreciate as to become part of the conversation. What has been done elsewhere, what has worked really well, what can be contextualized, to this particular area and what cannot, and what should we do, what are some of the lessons, especially that bit of what are some of the lessons learned. We really usually talk about success cases, we don't talk about failures, and some of the failures are really, really important for us. Yep.
Thanks a lot, Ryan. So the question on AI was the regulatory bits, consent, but to add to that, we're looking, so one of the problems we've been having with applying AI to the data we collect is the systems as they were built, you have to do a lot of wrangling of the data once it's produced for you to get to a point that it's ready to apply the models on. And we're looking now going forward that as we design these systems, as we build them, and as we operationalize the superhighway, is how can we have this data ready to be produced in a manner where the cleaning and the wrangling for AI is as minimal as it can possibly be, to allow for easier application of this model, so that we can start training our own radiological imaging models. The models, the HIV models, I'm told it took quite a while to get to a point where that data was now ready for modeling. But once it was there, then the use cases were pretty well done. Yeah, so AI has reached a point where it's no longer a buzzword. It's something that is now usable in different contexts, and we have to take advantage of that as soon as possible. Thank you. Momo.
Thank you very much. Can we give them another round of applause? For the interest of time, I know we have a lot of questions, but because we have such a section later in the afternoon, I think it's good we break up this time. Thank you very much, our panelists, for that excellent presentation of questions in this session. So I just request you to be seated. It is almost 1:30, and we had requested the delay for lunch a bit. So at this point, I want to request you to break for lunch, and we'll be seated again 2:15. The reason we are also late because during tea time, I think we really created a group of friends. We went next to almost 20 minutes, and now all the other interfaces. So I want to kindly request you to take first, only for you. Let's be seated so that we can go to the next session. And as we come back, everyone is seated at the back. I want this last row to be possible where Dr. Kimanga is. Those 2 rows, we find a way of fitting here so that the last areas rows can be left for the newcomers. It's an ample request so that again we can be together in this meeting. Yeah. The restaurant is 4th floor, just go down. Sorry, I think they have arranged it. Sorry. Where is the lunch? Is it here or down? Can you confirm, Grace? Yeah, there are 2 places. I want just to confirm. The other issue is we are under UNES Limited Twitter. Please just drop a like there. And also a watch. Yeah. So please, we Twitter also. Make sure that you do. So our lunch is served where we took our tea. And remember, when we continue sitting, we have only 45 minutes for it.
your first duty will be to welcome the head of directorate to officially open this Convergence meeting. Thank you. Welcome, Dr.
Yeah, good afternoon once again. Good afternoon. I hope our attrition rate is not only about 5%. But just leave your neighbor still around so that we can be sure we're not having a dangerous attrition rate. Then we hope those do not come in for lunch. So mine will be very simple, as you've been told. I've just been given a baton for the afternoon. I hope I'll be able to deliver the check on leading the group so that we can have a full discussion, especially on matters such as digitalization. I think without further ado, I'd like to invite our head of directorate. I was giving him a minute to catch his breath. I'd like to welcome our head of directorate, Dr. Beran Langat, to be able to give us some opening remarks. I'm sure you really have wished to be with us very early in the morning. And being that your IT people think you understand that thing called competing task. Our competing what? Resources. We are competing for resources. So it's my pleasure. Welcome to Charlie. Please give us our opening remarks.
Thank you, Wesley. Good afternoon. Yeah, my apologies. There are meetings at my door, but we have to stop all the things we do. So we have a meeting that we need to sort about in the morning. But I'm sure the team who is here will assist us in managing the session. The intention, of course, is always to make sure that the director can run without the gate. That should always be the case. And I'm getting a feedback that things have been moving very well. So maybe just as a way of introduction, I know I'm speaking with a lot of tech people. So, so my background is a bit different. I'm going to the statistics. My name is Dr. Langat. And I've sat with this team for the last 3 months. And trying to, when we came in as a new team, to try and conceptualize what exactly the businesses that the government should support and should invest in which environment that we need to provide. And I think we are very clear. I hope that my Deputy Director General, I'm still trying to get her to come and do the official opening. So I'm not going to do that. I just share the message that is emanating from the ministry. Hopefully she doesn't know today and she will be here tomorrow. Because these are big meetings. So the thinking was, and understand, government is thinking. So I don't think we want to compete in applications. We just want to make sure that there is sufficient leadership and guidance, whether it's through policies, whether by pronouncing ourselves on the direction that we want to take. And I think that has been my conversation for the last 3 months. And that is what has led to what you call digital super, what you call the Kenya digital super highway. It's basically, as a government, and I hope my team has also highlighted to you that we are seeing digitization as an enabler. It's the one that connects all the main investment you're talking about universal care coverage. You talk about human resources as one of the pillars, commodities, issues around financing, and of course digitization being the core. So ours is to facilitate and bring those efficiencies by making sure that people are able to talk to each other, systems are able to talk to each other. We agree on the rules of engagement. We are all in it, the private sector, the field sector, the government. We are profoundly investing in applications. We have got providers, whether or the payers, LHR, is all the health insurance, and even partners. And everybody has been investing on their own solution. I mean, if we don't provide guidance, what normally happens is that nature doesn't like vacuum, so people do their things. So we are hopeful, and that's why we call for this meeting, that with this direction that we are providing, Are we able to agree these are the rules of engagement? And from there, you can hold the government accountable in terms of making sure that the standards are there, that the governance framework is there, and I'm sure Joyce and the team has also shared that necessary regulatory, whether it's an act of parliament or even just regulation to accompany that act they are put in place. Yeah, is really about us as a government giving you that attention. So I want to encourage the conversation. This is a conversation we want to have. Hopefully by the time we leave here, we have a consensus. So now we want to engage ourselves. And that consensus, trust me, and now we commit, and I'm sure the government will definitely that's the direction we are going is whatever we have agreed here, then we look for resources to support it. I think every time we engage, even to the level of research of the president, they are always the idea that a patient, as provided by the digital data protection is the owner of their data. And that when a patient goes to a facility, because all these things we do is about the patient. When you appear in a local facility, you don't need to remember the last injection you got 20 years ago. For an operation, you can remember the details. You should be able to make that client have the records. Please, the right to have those records. And we'll give you the permission to can access it. Here is all about the patient. I don't think everything we do is built around that patient. It's not a cheap thing to build, but then we are committed to look for resources to do that. And I know there are questions that we raise whether it's still a pipe dream. Trust me, that is not the direction. But the pressure my team has at the moment is when are you giving us the requirements? Because we, in another 1 or 2 months, we are talking here, but I promise that by the end of this meeting, we have requirements that can assist us in terms of saying, who can we work to set up this? So one of the deliverables in this meeting, all my team is keeping track of that is the requirement. So it's not a dream, it's a reality that has to happen in the next few months. And resources will be available. I think that is the assurance will be given. And I know quite a number of partners are willing, countries are willing. So as the same always goes, it's not about the technology, it's about the people and the requirements. Please assist us in getting those requirements, right? And when we move here also, we want to ask you to be our champions. For us to have such a convergence meeting is an open discussion. Where did you get that? I'm sure you guys, most of you are working in this space. People don't usually their requirements at the back room and then they surprise you. So we are taking the bold steps to say what the channel that can assist us in dividing the direction we want to go. So I really want to request that whatever doubts that you have, go ahead and express it. Whatever things that you think should be done, please do that. Give us the input, we'll listen, we'll co-create, and the moment we say the direction, if these are true north, trust me, and also be all accountable for that, I'll go for that. As head of the directorate, and that is the expectation, that is the view that I do have to deliver that directorate, and I'm sure that is a view because of is a view that will share with the ministry, the leadership, that this is what the industry players are saying, and this is the direction we are going. So please, that is a request for me on behalf of my directorate. I'm sure they shared a lot of things, so let me not be the one to spoil the conversation that we had in the morning. But let's be here for the next 4 days. And if there's a partner, and I think I've got a lot of partners asking me, it's an open, I can see enough spaces here. We welcome you. Just bring them here. I noticed one of our few critical partners are not here, but my team told me. KEMSA and NHI, but we just with the CEO of the KEMSA, the acting CEO of the government, we have seen how we can get moving. We had a conversation also with NHI. Yeah, because when you talk about the core system the government is looking at, everybody's worried. Of course, there is a shared services. That is a no-brainer because there is a lot of stuff to talk to each other. But everyone is worried about financing. And we are not looking at financing, just insurance. As the team probably told you that we are also proposing to finance the primary health care level. And actually, the healthcare financing team are trying to correct the numbers. Nobody has ever posted what it takes to deliver the primary care services. The obvious one, everybody knows, curative level. We have been paying as insurance, and the government is going to cover population. We're also trying to see how to cover the chronic and emergency services, because that's what the Constitution also is asking us, that if a patient arrives in your outpatient emergency department, you stabilize, and then you send. They spend their resources. So how do we then reimburse those people? So even as we do all this, the number is not just about insurance, it's about the primary health care. But any other funding that the government is proposing, we already have a partner. So how do we facilitate a common platform that can not just standardize, but everybody knows what are the tariffs. We know that we are paid A in this facility, and then we don't move across to another again and we get paid. The other thing also is about the tracing of commodities, and we are in agreement even with KEMSA that when we talk about end-to-end, it's both ways. At the level of dispensing, you should be able to know who is consuming. At the level of that is so most of the time it comes to your facility, you receive, especially for government facilities. As soon as it is the business of KEMSA ends. But you are saying that when you talk about end-to-end, it is that you receive and there's a feedback that you receive. And likewise also you need to know what is in your store, what is available, so that you can order, so that you get a proper order field. And of course the big issues about telemedicine, and I'm sure Joyce mentioned that there are guidelines that we are trying to develop so that it can guide how telemedicine is being provided in this country. So it's a lot of things we are trying to do in the short time that we have. And we are consolidating, we are writing on the investment that has been done before. You have thought about it, the architecture I think was very easily as well when it was developed. But I think this is the time to operationalize it, to make it work. And time is not, I keep on giving an example to my colleagues here, that when you explain to the president that you need time, it's not something we want to hear. Because he asked me what you require to reduce that time. And the object mentioned example is farmers were registered in 3 weeks. So it's not about resources, we get the resources. It's not about, so just what exactly, I think the limitation which has always been for us is to get the requirements right. And we have been postponing this until this week. Yeah. So let's, it's a question, I've always, don't think about the money, just think about what we can first. The question of money will close the river. You don't have to do everything at the same time. You can do it in a phased manner, but if you are very clear on the requirement, then anyway, why don't you go and present your budget and your total? So we should be, I think that really should be the principle that we as a health sector, the president and I mean, that is the biggest advocate we can ever get. Every time he has talked about health promoters for almost, I don't know how many months now. Yeah, and we are a bit embarrassed on our end that we promised to digitize that level. So I mean, hopefully in the next 2 months, we will have digitized completely the level 1. 100,000 family of promoters paid for both by county government and also by the national government, each with a gadget that is able to register all the households and manage all the preventive services. That is really an amazing information we generate. Yeah, because it's complete registration of households. The data that we are collecting there is huge. Sometimes when you get the program, you want to do mass net distribution. The first thing you do is what? Household registration. You want to do the residual spray. The first thing you do is household registration. There is no theft, and this is the truth. There is no theft that occurs in a community that is not known. Yeah? I've never seen a situation that happens that is not known. But there's a problem when it comes from being known and being notified. Even a child being born is a celebration for the community. Everybody knows. Mtoto amezaliwa. And those are the things that we expect EGs to sort out because they will tell us there's an agenda that has been reported. So the next question is how to then use that information to make sure that notification is done officially and therefore the relevant authorities have to see. And you know, that is the idea about digitization. Is the moment we work with the communities, we have digitized that, then we think data and information will be available, is us to use it. And I'm sure Joyce must have mentioned that we then want to build the capacity for analysis, analytic capacities. Yeah, because we are collecting a lot of whether it's water and sanitation, whether it's household income, we are collecting a lot of that, and we want to build that capacity. So anything as we talk about this digitization is work with my team to build the capacity for analytics, modeling, predictions. We want to support programs. So digitization is just about analytics in itself. I know we have been doing some work on community-based surveillance. Do we need to duplicate that? Surveillance, public health reporting. I know there are people here, so I know a global here is we talk about reporting on tuberculosis. So the next stage is that you don't have paper. You don't have the registers. I worked on tuberculosis space for many years, so I know what they normally say. The treatment registers and then the one registers for the coordinators. We are, I mean, we would not want to ask somebody who has an EMR or HMIS, whatever you want to call it, to generate papers again for the register. So we want to facilitate you, and that is why another kind of public health reporting. You only need to tell us this is what I require, the data to be either automatically updated, or we generate you those like listing of the patients. That is the ambition at our level, that we are able to support everyone who is in need of whatever form of information. We know that is big, but we are here with your support. And I've seen a lot of partners coming. I think I've met more than, I don't know, about counted, but close to 30 partners. And yeah, most of the time, 7:30 in the morning, late in the evening, some are coffee, some are virtual, some are physical. But the idea is, for us, is to know that we want to listen to you first. We are not going to dictate, but the moment we have said this is the direction, I'm hopeful that we don't be very far behind. But I also know, of course, sometimes people have difficulty in training. There are those who are, people who want to come in late. Someone will change. But if we have the majority, then I know we'll be somewhere. So with that, really let me not do a long talk, but just appreciate having more than 100 people. I think I signed in and I was 155. Well, was the last one I saw it is 155. So that is a huge number. And I don't think these people are just coming to just, they are coming here because they have an interest, they have a stake. And then for my team, this is your champions. Yeah. The fact that somebody has willingly come here and willing to spend 5 days, I think we have already achieved the first objective, is to get people to work with us the journey of business champions. Let's give a tap of this to see how we can support, how we build a community of practice, I think the other day we were discussing, we were trying to put up a digital strategy in a short time. Simple one. I don't know whether you want to share that. Is still, you can share that with other people, because when we joined also we realized we didn't have a digital strategy. So we just said, can we in one day just try to see how would it look like? And we have a zero. I think we also share that. Yeah, so that it can guide to us or what we are doing. And a lot of things was some solutions that we think can be public good, but we require community of practice. So I'm hopeful that you're also going to guide us on how can we get this conversation moving, not because we created this for this session, but can it be a continuous engagement. Joyce, I think here you can also get some of these to technical working groups, how we define our ICCs, because those are the structures that will assist us. They're not just at this level. Most of you are also operating at the county level. Can you also replicate the same capacities at the county level? Because that is where the action is, that is where the effect is. So please, I also encourage you to make sure that we replicate that. That is all the best, and I would promise to be here to listen. In case I disappear, it's not because I don't think this meeting is important, because I said sometimes there's someone, and we just have to obey. Thank you.
Yeah, thank you very much, Dr. Manat. I think you can do a better clap. I don't know how many of you know something called wheel polo. I happen to have worked in Nyanza where I began my work, and it's something they call wheel polo. Wheel polo is something like thunder, you know thunder? So I want us to cut in 3 thunders very, very fast, so that also the food can move in our body. Is that okay? Yes. So let's warm 1, 2, 3, 1. 1, 2, 3, 1. 1, 2, 3. Very, very well. So I'm reminded kindly, for purposes of accountability, I think you can see we have a number of sponsors for this particular meeting. So if you've not signed the AMREF form, Martin, please stand up so that they can be able to see you. You can just raise your hand so that at least he ensures that you register. I think most of you are familiar with this new term called accountability. We also insisting that accountability is done also on our side. So we're about to move to the next session, and I would like to invite Dr. Nyotu to come and give us. We'll have a number of panelists here. And the main thing, as you've been able to see, Dr. has given us a very good insight that we have blessing from the house in the hill. And anytime you have blessing to the house in the hill, it is your responsibility to take advantage before the grace goes away, because it can go away. I think most of you are familiar. We had UHC previously, we had all the graces, and along the way, some people say BBI took it away. So this is our chance. Let's try and focus on it. And most importantly, mine is to sensitize on why we're here. We're here to be able to start this journey with you together. So that as we look at digitalization, all of you will say we started with us here, and this is where we're going. This is what we looked at, maybe about financing, the guidelines, the standards, so that along the way, none of us will be able to say, you need to do MOH as we are there. We're going to work with you all through this journey. So, Dr. Nyotu, kindly for the panelists.
Thank you very much, Dr. West, for being the MC for this particular session. Thank you very much, Dr. Lagach and Karibu Sana. It's been a good session so far. But we have made a few changes to the program. We noticed in the morning we were on the panel a lot. We were here a lot. The MOH spoke and spoke and spoke. We've given the vision. But just as we're saying about being inclusive, we've changed the panel format. So for the afternoon session, this session, we want to capture the knowledge. Let's hear from the people who've been implementing different aspects. Let's hear from the players who are here, who worked with us in the previous journey. So if you allow me, I'll introduce the panelists for this next session. We'll have 6 of them coming to take us through different experiences. So first on the list, I'd like to call up Jacob Riambo from Palladium, who's going to be representing the stream of infrastructure in the discussion that we're going to be having. Next, I'd like to invite William Hayes from GEMI Health System, who's also going to be talking to us about his experience implementing client registry.
And then also next, we want to invite Mr. William Kiama from the Association of Kenya Insurers, who've been doing quite a bit of work in terms of implementing a HIE for the private sector for insurance. Next, just please come and take a slot. Next up, we have Robert Mutai, who is leading some of our efforts from the private sector implementing model in digitizing the level one level of our healthcare system, and that is the community through ICHIS. Next, we have Dr. Ngure Nyaga, one of the from Savannah Informatics, who has a lot of experience with implementing different types of services, and both in the private sector and even public goods within the Kenyan ecosystem. Next, we have Dr. Thomas Moki from Moi Teaching and Referral Hospital, who has quite a bit of extensive work experience also being in the sector. And for the panel, this panel shall be moderated by one of our deans of digital health, the one, Steve Wanye. Karibu sana. I give the panel over now to Steve to run the session. You can have the mic for the panelists. You can have the mic for the panelists. And I'm being reminded that we are gender insensitive.
Yes.
We agree. So, who do you want to lead the panel? Or yes. Okay, who's volunteering to please step up? We can get a chair. We can get an additional chair. Who's willing to step up? Ladies.
There's a volunteer here.
Catherine, yes. So we'll get a chair. We'll get a chair, and thanks, Catherine. Let's clap for Catherine. So, as been mentioned by Dr. Nyotu, the purpose of today's afternoon after lunch session is to get a little bit into the details of what these fine gentlemen and fine lady are doing in support of the Ministry of Health efforts in Kenya, but also draw on their expertise and experience, even in other countries. So we're going to have very, very honest conversations, and we won't give them time to make speeches. They need to answer questions. And we also have questions as well from the audience. So that's really the purpose of this conversation. And the idea is twofold. One, we want to hear them speak authoritatively, technically, about their area. So the question will be around the area you're working in. Can you be authoritative about what is the current technology, interventions, and approaches that Ministry of Health should adopt? So, for example, I'm looking at William. I'm talking about personal identification. We want William to speak authoritatively, right? That's why he's been invited up here. And tell us what has he done, William Oxford Jeremy, in South Africa, in other countries, including Kenya, with regards to identification of consumers of healthcare. That's one part. And the second part that I want to hear from William, as an example, is what does the ministry need to do? As Dr. Langat has mentioned, the ministry's responsibility is the enabling environment. So William needs to say, this is the technology fact about client registries and how it should be designed and how it should be implemented. And we'll give a chance to the audience to challenge that. That's why, as Dr. Joe mentioned earlier, Ministry was very clear about who to invite, so that we can have honest discussions, because you're all professionals here. So that's really the sort of the two-sided part of this panel. One, technical expertise and certainty and authority, because that's what you've been doing for years. That's what you know, that's what you're trained in, and that's what you're strongly recommending, sitting up here without any fear of contradiction, that this is what I believe in and I represent a constituency. We also know, for example, there are people here who are working in client identification and client registry. So when William speaks, we want to hear from you. Again, we'll carry over this work tomorrow into group discussions, so this is what we are starting off with today. But again, as Dr. Langat mentioned, this is the start of a conversation, and that's the purpose of this panel. It's a conversation, so they're not speaking to you.
we are all having a conversation, but since we all can't be here, we need to find a structure that works for all of us. So if that is fine, I think we shall begin. And first thing I'll do is request a panelist here to introduce yourself really, really briefly. Just tell us who you are, a little bit about yourself, very, very briefly about yourself, to get to know your background professionally and who you represent here. And then after that, I'll get the questions. So we'll start here. So please tell us your name, affiliation, a little bit about your background professionally, and then we'll move on.
Good afternoon. My name is Catherine Mosile with Consultancy. My background is in the insurance industry, health insurance industry for 15 years. My expertise is healthcare financing.
My name is I'm a software lecturer for Goa Postgraduate Technology. I'm one of the founders of a company called 17TH. 17TH does claims exchange. So connects insurers, hospitals, and most benefit. That's my expertise.
Good afternoon. I'm William Hayes from JP. I'm sure I'm the oldest person in the room here. But we also work with technology that keeps on changing. So in that way, we always have we all have to stay up to
Good afternoon. My name is Kiama William. I work for the Association of Kenya Insurers. I'm in charge of general insurance business, medical insurance business for the general insurance. So I've been in that business for 25 years.
Good afternoon, everyone. My name is Jacob Ogiambo. I work in India. I did a project with HMIS. What we do is that we support digital health, develop digital health systems for HIV and control. We also manage data and stuff. My background, I'm a doctor.
Good afternoon. My name is Robert Zay. I work with Medic. Medic digital tools that empower and support care. I have been in the technology field for about 18 years, previously in the telecommunications sector, but now in the digital space. Very happy to this session.
Good afternoon. I'm Dr. Thomas Bubi. I'm a physician by training. I also a health informatician. I'm the Chief Information Officer at Convergence Hospital. So I think in this panel I'm presenting, let's say, that there are about 6 hospitals. What should we expect of systems? And we involve in an in-house system that runs the entire hospital, all the aspects, right, from procurement, finance, demand, treatment of the system. We are very excited to see how we are going to plug into this national infrastructure.
Right, thank you very much. If I could ask the person who's running the slides to please put up the digital health superhighway. That's going to be a reference with these panelists. And so I think we'll start right here with Catherine. And the question I have for you is, given that this is the vision the ministry has shared with us, we realize that one of the areas that we need to transform using digital health is health insurance and financing. So, number one, where do you think the country truly is at with regards to health insurance and financing from a digital perspective? What do you think needs to be done? And then what do you want the ministry to do to make sure that that happens?
Thank you. I think first of all is to acknowledge the journey in terms of how far we have come. Let me speak more so from the private sector perspective. This is an industry that has had several challenges in terms of the growth of the sector, coming from the fact that it's been a very manual business. So I had some health facilities talking about that. And we've really tried to come of age, especially with partners like my colleague who is seated next year, in terms of identifying processes where we're able to move from paper-based business to digital. Why? Because one of the things that's very fundamental to be able to digitize business is that it really helps to carbon fraud. Papers, from the insurance or the health financing perspective, the papers really have created a lot of room for fraud because it allows people to go back and manipulate documents. That's why. Two, another development that we have seen in the sector is something called patient identification. So in the private sector, the market used to have what you call a photocard, pretty much like a national ID, that's what we would call it. And this is a document that in many shapes and forms could be, recreated to have almost ID fraud. So what happened is that the market evolved into using one of, either OTP, one-time PIN identification, and also, thumbprint identification as well. And those have helped to cover things. But still, we have a long way to go because the number of people who can access care remain very few. Why? Because cost of healthcare continues to escalate day in, day out. So while you steal your loopholes in terms of inefficiencies, when you talk about administration, whether it's papers and moving on to better identification of people and reducing fraud, there's still a lot of challenges as far as it goes in terms of being able to support claims cost of care. And that is where we feel that there's still a lot of room in terms of the government also working to be able to facilitate standardization, because you're dealing in a market whereby drugs are identified in all forms and shapes by every healthcare facility. Procedures are identified in any shape and form as well. The only thing that's pretty much standardized right now is probably the disease, ICD-10 coding. The rest is still a long way to go, and that needs to be standardized so that people can be able to have transparency in terms of information, to know that a cost of this drug should be this, a cost of this procedure should be this. That's one. Two, I think the other thing, while the private sector has made a long effort in terms of being able to identify patients and reduce fraud, we still have a lot of challenges in data interoperability, or rather even in terms of member identification. Let me clarify that. So I go by the names Catherine, Harori, Kosiki. So when I move from insurer A to B, or I go from healthcare facility A and B, the data that is captured about me as an individual is very different. So you find that in the end, when you're being able to track history of patient in terms of treatment, the services that are being rendered, it really is diverse. So you're not able to have a standardization and be able to have interoperability of information. Finally, I think the other thing that we see is that even healthcare facilities do not seem to trust each other's information. So there's a lot of discussion around, patient history. So you move from provider A to B, provider B saying, no, I need to retest the following because I don't trust the other provider. So what does that mean? It means that in the end, healthcare becomes expensive because nobody is being able to trust the other in terms of being able to make right health judgments, and in the end, the cost of healthcare is becoming more expensive. So from a healthcare perspective, are we making progress? Yes, we are, because we have more repayment mechanisms. Hopefully, we are still not out of pocket expenditure, but we want to be able, there's a lot of drive by the government to be able to push for more of prepayment mechanisms, NHIS notably, and private health insurance. But there's still a long way in terms of this enabler, transparency of data, transparency of cost, being able to have member identification that are fairly unique so that you can be able to hold history of a patient. So that will be good enablers, and those are some of the things the government needs to think about to be able to enable a better healthcare financing.
Thanks a lot, Catherine. So it's really quickly what about from Catherine is, it's a very clear case for digitalizing health insurance and financing to reduce fraud, improve and increase patient identification. Data interoperability is a big problem, and trust is a big problem. Are there any comments from the audience about that component of, you can look up here, where there is the electronic claims management system. Anybody with an opposing view or additional to what Catherine mentioned? Just want to get a bit of appetite and sense of that component, in addition to what the panelists mentioned. Anybody with a planning contribution, addition to that? Dr. Joe,
thanks a lot, Catherine, for that exposition. My question is on how do you see this working from the government side and interfacing with the current private providers of electronic identification between, the claims one basically. So, the smart, the savant of this world. What's our role as government? What's their role? Because we don't want to, we're still about job creation. We don't want to end some sectors. Yeah, that's my question.
I think government should be an enabler. We are coming from the perspective that, and I will allow maybe my colleague as well, because we are all together in the same assignment, the Association of Health Insurers to speak. The private sector has actually contemplated its own health information exchange. And the way we see it, that to undertake an initiative of standardizing all treatments, standardizing all drugs, standardizing procedures is a good to do, but probably bigger than us. And so that the government will be an enabler in terms of creating a platform so that business can train. We can do what we need to do. And that if it talks about things like terminology, there is standardization of that this means the same thing in every sector, that is important. So being an enabler to create standardization is important, because many IT firms, like my colleague here and several others in this room, have had to build things from scratch. They've had to go and sit down with the hospital and say, okay, augmenting this milligram. Okay, so what code do you use for it? And some of these things, if you ask me, I'm not an expert in that line specifically, but if the drugs are originating maybe from cancer or whichever other body is governing that, why do you not have that standardization? One. Two, the government holds the master database of all facilities in this country. Why did we not use that? Why is private sector having to use different names? You go and use Aga Khan University Hospital, Aga Khan Hospital. They go by so many names. Doctors, some of them use their clinic names, some of them use their own names. If we can have the government be an enabler of standardizing information, and then we create the platform for harmonization.
Thanks a lot, Kathy. So we've got 1 hour, so I think I will also have to control this conversation, getting very interesting. But I think since Kiama's name has been mentioned, I think it's only fair to give him a chance to comment about that. But I think as we do that, Kathy has made some really strong comments about the need for standardization. Now, how many people know about the National Health Data Dictionary in this room? Kathy doesn't know, right? A little bit, yeah. So government has established a technology service called an NHDD, right? To solve exactly the problem that Kathy is talking about. But obviously there's a problem, isn't it? Yeah, the private health insurance don't know about it. So government has done something it's not known. Is that a common problem? Tulisema tunaongea ukweli leo. And Dr. Langat has allowed us to speak openly, yeah? I think the point I'm trying to bring with this is that we need to have this conversation at least on from today until Friday. Otherwise, if we don't get out of this comfort zone, we won't be able to get real solutions. So, Kiama, tell us your thoughts and additions to what Catherine has mentioned.
Yeah, thank you very much. Just want to add to what Catherine has said. Standardization, I think, has been our key major problem in the industry, and we started from very far. Looking at even the forms that we have in terms of correct data. You will go to company X, you find the proposal form that we have is very different from the other insurance company. You go to what we call pre-authorization forms for doctors. Like you are now, you are in Nairobi Hospital, I give you a form, you ask me which insurer I come from, I tell you I'm from APA. Then you need to struggle to look at where do I insert the ailment, where do I insert my signature. So what we have done is we have started to come up with those standardization. We standardized those forms, the application form, the authorization forms. So all those forms have now been standardized. But what we think the government, as Captain mentioned, should be a big enabler in this area. So that then, if you want to identify Kiama, it is the same Kiama you identify in hospital A, in hospital B, in hospital C. So that since Kiama is allowed to visit all the hospitals, then we'll know the ailment that brought Kiama here was X. Then when you go to hospital Y, I do not have to repeat the test that he did in hospital A because I can already see them. And that, to me, that is where we have a lot of risk. And that is why you see medical insurance premiums going up, so that we don't have, now the middle class is almost unable to afford even the medical insurance, because the premiums have been going up and up and up. Why are they going up? Because of this waste. Because last week I was tested for X, Y, and Z, but since the doctor that I'm visiting this week because I'm feeling a bit unwell, doesn't know what I went through, or she doesn't have those documents, then it means they will have to do a if the government was able again to now have that unique identifier for everybody, so that even if I am in Malta, even if I am in Nairobi, then you are able to pull my records wherever I am, then that is going to be a very big deal. And to me, that premiums will maybe start because they will not have problem with this. We had thought there before that maybe fraud was a major cause of losses in the insurance industry. For your information, apart from the COVID 2020, the insurance industry made some profit. The insurance industry has been making losses all through with medical insurance. We have 36 companies that are supposed to be, that are licensed to give medical insurance, but we have only 16 who are giving medical insurance. The rest have said no, this is a no-go zone. It's like a matatu business. Last year we had one insurance company exiting the medical field. Why are they exiting? Because of those costs. So if we are able to manage them in terms of those kind of interventions, the taxation we are talking about, and I think we are going to make even the persons there at the bottom of the pyramid to be able to access some form of medical insurance.
Thank you, Kama. I'll invite Dr. Ngure because Dr. Ngure has mentioned done quite a lot of work in digitizing health insurance, built an information exchange. So Dr. Ngure, what are your comments about this? Are these wild allegations? Are they true? How have you solved the problem partially? Please, got 5 minutes.
Thank you. I didn't have less than 5 minutes. So, the question about what should the government? I'll still appraise from front of mind. Convene, collect, catalyze. That's something a government is uniquely positioned to do. Convene, unite, priorities. Collect, we are all discussing, and over the end of the week, we'll have to have a shared input. Catalyze, give some impetus to the industry to actually make changes. Then, I think I have a challenge for the entire sector, economies here. If you've been in the space for a decade or close to 2 decades, you'll know that we've had these meetings before, these discussions. Even in the insurance sector, there was a 2011 attempt to standardize the claims and periods. Can this time be different? Can we go beyond talking to actually getting it? Yeah. Then on the more technical side, I have some 3 comments. So the first comment is about open access to APIs. What does that mean? We have LHD. It exists. It's good. Have we figured out how does the sector access LHD? Is it documented? Are there clear checklists and on-ramps with clear criteria to access it? Do I need to know Dr. Nyotu or Dr. Nyangena to access it? And I think that will be one of the things we need to really sort out to catalyze this. Then, when it comes to the actual content of this highway, many of us in the industry have had to reinvent these things. If I look at the list of things on this, I'm looking at the list of things that were forced by circumstance to invent for ourselves, and that's not value adding work. So it's high time as a sector we agree that we can standardize basic things, client registries, terminologies, shared health records, the entire laundry list that's here. Then we can now focus our energies on innovating about that and delivering value to our people. And that I can say even in the presence of our competitors, because the opportunity to innovate for people is so big that just because we standardized a client registry doesn't make us go now. Then I think the last comment I'll make, it's almost like my first, but very different. It's about the uniqueness of government. So who registers doctors? It's the government. Who registers CEOs? It's the government. Who registers medicines? It's the government. So who is best placed to be the authoritative publisher of codes and technologies? It's an entity. And then all the rest of us can, within the governance framework, use that to build support. Thank you.
Thank you very much, Dr. Ngure. Those are really, really clear points made there about we need to go beyond rhetoric. We need to have an action plan, and Dr. Langat has promised us that whatever we come out of with this week is going to be implemented. The highest office possible in this country. So I think we've got that commitment from government. So let's also do our part as well this week and see what we can do. For one of the comments made by Dr. Ngure, there's a burning comment at the back, so let's hear that. But I think as we do that, I'll ask Dr. Jacob to provide a bit of updates about some of the services that have been mentioned by Kema, by Catherine, by Dr. Ngure, how to do with established services. So the question here that I think we need to start tackling today, and we can't finish on this panel, why aren't they being used? So Jacob will talk about NHDD, how it was set up, who's using it currently, and why it's not being used as it should be. So,
good afternoon. Just to, my name is Dr. Njoki Fernandez. Just to add on to what Catherine and Kema have said, one of the biggest concerns that I think also increases the cost of care is that, and in all these systems, I have not seen it so far, somebody tracking the quality of care that is given to the patient. We are seeing the patient has come, they have been treated, and they've gone. But what treatment have they been given? For what diagnosis? What tests were done? What medication was given? Is there logic in that treatment plan? Or shall we give treatment X and in 2 days the patient has come back because maybe the treatment didn't work, we didn't investigate them properly, and they come back with the disease not being treated or even with complications. We've seen some insurance providers saying that they will no longer allow for the use of maybe cough syrup because they say that cough syrup is not supposed to be used in treatment of pediatric coughs and flus. What are the treatment guidelines? Are the medical practitioners actually adhering to the proper treatment guidelines? And who monitors that? Because if we do whatever we like, that really, really increases the cost of care. The other day I saw a report in in the dailies that our cesarean section rate is 50%. Is that the right thing? Is that the proper thing? Is that a conversation we should be having? Things like that. Are we measuring outcomes? Are we measuring quality? Or are we just collecting data? Collecting data for data's sake, I think there needs to be more than that. Thank you.
Thank you, Dr. Njoki. Request Dr. Ryan to make some comments. Very, very interesting questions about quality of care, tracking quality of care. What Dr. Njoki mentioned about elective cesarean section. Currently, the data says that women in Nairobi are too push. So, Dr. Ryan.
Thank you very much, Dr. Njoki. I think maybe that's an interesting comment, but by the end of the week, I'm sure you will see how quality is being tracked by implementing this. Because one of the registries that's on the slide, and I don't think it's on this particular slide, it was on the one with the slide with the digitizing the primary care network. One of the places where we're putting the guidelines and the tariffs is the guidelines and tariffs register. And this will be linked across the entire sector. And this will be developed from the point of view of the providers and the clinicians through their associations and the engagements we'll have with them. What this will ensure is not only will it allow us to track quality, it allows us to develop models of how we're going to implement improving the quality. Because, for example, if we know where you are seen, if we know who saw you, and we know what drug was given to you, and we have and all that data can be compared and matched against a guidelines registry. If you go away from best industry practices, if you go away from practices, we're able to track that. The insurance is able to ask questions about why are you doing this as opposed to this, yet the whole sector is doing this. So just by implementation of this, quality is one of the innate features of this system. Thank you.
Yeah, so in the morning when we talked about the vision, I did talk about data governance principles, and one of those, the categories was to protect people and communities. The protection includes ensuring that quality of healthcare, quality services are provided. I also mentioned that there'll come a time when we even have accreditation of health services. The accreditation will be based on quality of services being provided. But lastly, just to zoom in, for example, at Kitengela Sub-County Hospital, they have been paperless. And when you do go to that facility, you see the quality aspect in action right there. Because right from even the way the medicines are prescribed, you can tell who has prescribed what and go back. And that's not a story that we are the ones who create. It is the clinicians on the ground who actually tell me, ever since we went paperless, ever since we started using EHR, that the quality of services has improved because we know who, and even you as the clinician, you know that if you go messing up, it will be identified. So they know even who to give OJT to based on what they are seeing along the cascade of care. So they're not just collecting data for the sake of it. One of the other principles of health data governance, which I mentioned in the morning, was to prioritize data use at all levels.
Thank you, Dr. Wanishe. I think I'll invite Dr. Jacob. You can get the mic to Dr. Jacob. Thank you. Dr. Jacob, I think as you introduce yourself and make broad comments about which areas you've been contributing to for many years with your past experience and current support to the Ministry of Health, if you kindly comment to these key questions that are coming out very clearly. In that diagram, there are green boxes. The green boxes means that Ministry is saying these services are available. Evidently, not everyone knows about them, and not everyone is using them. Yet they're there, and government has put a lot of efforts, resources to availing them. So if you could comment about your experience and also just your observation about that situation. Jacob. Thank you. Thanks, Steve. I think maybe just before I do that, just to comment about the role of people health in enforcing guidelines. I think in the HIV program, what we have done is to come up with what we call decision support features in the system, so that if anytime you find that it's very difficult to train all healthcare providers on what they should do as per guidelines as soon as they are rolled out. So what the systems can do is to help providers to be alerted of services that are due to a plan, so that they are more likely to comply with the guidelines requirements. But I think just to respond to what Steve has talked about, over the last several years, we've been implementing several digital health solution facilities. And one of the things that we noticed is that some of the systems do not really maintain the dictionaries. Right? You find, for example, an application has age and sex in two different forms, but they do not really relate to the same thing. Right? And that was a big problem, especially when you are trying to migrate data or integrate systems. So with MY leadership, I think we participated alongside others in this group in developing the terminology services. And what that basically does is that you adopt global libraries for terminologies, and then we domesticate it locally, so that any system that is being developed in the sector can refer to these terminologies when they're designing their forms and their data collection tools. What this does is that when you are now going to interoperability, you have a common reference point for the terminologies that are used in the systems. This has helped us a lot, especially with the other partners that we exchange data with. Whenever we are considering terminologies in interoperability, the first thing we do is to just make sure that the data sets we want to exchange are within the NAPD, and therefore we know that we'll be meaning the same thing when exchanging data. In terms of the Kenya Health Master Facility List, we currently have applications in over 1,900 facilities in Kenya. And the reason one of the things that we like to, we ensure that we do is to make sure that these facilities are unique facilities. When you are the Kenya Health Master Facility List, when you go to the Kenya Health Master Facility List, one of the things you'll notice is that there are facilities that have different names, similar names. The only thing that's different is whether it's a dispensary, it's a nursing home, or a health center. So with the Ministry of Health having formed the Kenya Health Master Facility List, it means that you can actually refer to a common list of facilities which are coded uniquely, and you're able to know which facilities are offering services. Now, when you really think about it, when you're doing referral services, it's very easy to confuse a patient by giving them the wrong facility name. When you're doing reporting and you want to share data with KHIS electronically from your system, you must map the same facility in your system to the one that's in KHIS, because that means that you do not assign wrong reports to different facilities, which is a an accountability issue when you think about how the health services are funded, especially for the public health services that patients do not pay for. I think the final one is the community health registry. I don't think I've had a chance to interact with that, so I may not comment on it at this point. I can't speak.
Thank you very much, Jacob. I want to ask a provocative question to the audience. Especially if you're not working in public health, who has tried to access these services? The ones in green, color green. Who knew about this and who did not know about this and you just found about them today? Let's be honest, so that we can actually address the real issues. Because these services are there, and they were set up to solve very, very clear challenges. As Jacob has mentioned, if you're supporting any health facility in Kenya, they are all listed in the Kenya Health Master Facility. So you shouldn't be second guessing what facilities are in Kenya and what services they provide. Did you know about KHMFL? You didn't know. Did you know about NHDD and what it's supposed to solve, what problems it's supposed to solve? Job talked about semantic interoperability in the morning, isn't it? So that when you call something in, same thing in Nyanza, it's called the same thing in Nairobi. That's what that is, the dictionary for, and ensuring that the language is the same. So these services are there. The ones in green are there, they are functional. They've been working for a long time, but evidently there's another problem we need to solve, isn't it? So the reason that we have in this level of conversation so that we can actually have the right tone as we get into the groups from tomorrow, so that we can come up with new solutions and requirements, as Dr. Langat has asked, so that government can actually solve the right problem. But if we don't do that and we are a bit shy, then we won't really solve the true problems. Yeah? So one of the things that has come up quite a bit is client identification, isn't it? That's a big problem. As you can see here, it's what color? Yeah. Do we have a client registry again? How are we identified as Kenyans and people who visit Kenya? What service do government use to identify us? We don't even know how we identify. Yeah? We know IP address, we know Huduma number, we know all those things, right? Ministry is part of government, right? So it's part of that initiative to solve that problem of identifying persons uniquely. So there's nothing that's being reinvented, but for the health sector, there are other considerations that need to be taken into place. So let me ask William to comment about client registry. What are the things that we need to really take into serious account as we are trying to solve this problem for the health sector and establish and make sure that red box is green, maybe by the end of this week. So William, if you could share your opinions, your experiences, and your recommendations in 5 minutes.
Okay, so 5 minutes. So we are not interested in APIs because the CPC wanted to evaluate two APIs out in the field. And that was the first time I'd ever really heard about APIs thinking and resolution a couple of years ago. I really come from banking, security, and things like this. So you know, with that in mind, just let's just talk about what is a client registry really? Except, you know, it's just a service that links a whole bunch of interactions together. That is my mechanism of an ID. And so this ID is fundamental. There's an ID that links all the interactions. There's the lab interaction, the pharmacy, the doctor. That's what it is. Very simple. But it comes with an incredible sort of there's danger in this thing as well. And so I'm going to thank Dr. Joyce. She's someone who mentioned the most valuable player in the room for bringing up the concept of profiling. And that really is really my focus here, is the danger of profiling with IDs. Okay, so I'm here with my colleagues. She's not really my colleagues, she's more, she's really my friend, like Natasha. And you know, like I'm sure everybody has noticed, like I'm completely different skin color from all you guys, except for Natasha. And I really come from truly describe it as an ecosystem. 50 years ago, 40 years ago, I could sit next to her on a bench. That that is the cost of profiling. But it was also apartheid was also a system that was never ever going to try. It was going to get defeated. It just was. But now we enter a new era, the era of IT. IT can also be erased in terms of that. So almost like coded, like Netflix is a really coded bias in terms of machine learning, artificial intelligence, things like this. These things they profile you, and they've got dire consequences if you don't get it right. So this CR we talk about, things like this. There's no use having a CR that's fantastic. I go to one facility, I go to another facility, and get my drugs. They know that the doctor subscribe, but I can also be profiled for this thing. So that whole system needs to be protected. And if there was sort of one question that I could walk away from this, especially at national government level, to understand the seriousness of the approach CRs. Especially with AI and machine learning, IT makes it very, very easy to IT is a way you control people. I come from a part of the positive implementation. I don't know if anybody.
Thank you, William. Anybody here who's working on solving that problem of unique identification? And you have a strong opinion, a strong comment you want to make at this point? We're going to have a lot of opportunities again from tomorrow. So again, like I mentioned today, and I know one of the persons who worked for a long time in that area is George Wiso. So maybe George, you could mention a little bit the work that you supported the Ministry of Health. Actually, and I could ask George to speak about the policy. How many of us here know that there is a policy on unique identification in Kenya? How many have read it? What does it say about the thing that William mentioned about discrimination is a big one? It has potential for serious harm. Who knows what is in there to help protect that? Dr. Joyce mentioned about protect people and communities, right? CR is a very dangerous weapon, but we also know we need it, right? So there's a policy, there's a framework, especially around the data. Technology is not really an issue, I don't think, but it's really everything else around that process of identification. So George, please comment about those sensitive issues around patient identification and personal identification.
Thank you, Steve. I think, as you say, one flip side, unique identification is wonderful, and definitely, potentially, we shouldn't discuss the possibility of data exchange if we don't consider unique identification. Data exchange is a moot point if we are not going to uniquely identify individuals. However, how we go about it, and I think one core thing about identification, that it has to be managed and run by the government. Not that people don't trust the government, but the ultimate accountability has to be high enough that they can invest whatever resources it is to protect the identity of persons. Most healthcare workers would tell you that where unique identification, any semblance of unique identification has been implemented, the benefits far outweigh the risks. However, for vulnerable groups, there have been concerns that identification can lead to discrimination. And one way of ensuring you don't do that is not even from the technology side. Make unique identification a universal thing in health. Don't make it for a specific population or subpopulation, but make it as a way of an implementation that serves the health sector. And therefore, the same way George is being identified as a client to health services, it is agnostic to the type of health service I'm going to receive. It could be that I am a TB client or a HIV client, and I know key populations have always raised an issue with the fact that it will be used to identify them. And therefore, when we'll be having discussions about the shared health record and why it is important to ensure that the medical record on its own should not be self-disclosing. Whatever value you attach to the shared health record at rest should not be self-disclosing. And that would be a very important implementation discussion that we have. If we have implementations where your identification information is together with your medical record, then all those concerns become fuzzy. When they are, we use technology and other measures to ensure that they are not together at any given time, then you already minimize the risk of unintended disclosure. But the technology we use definitely will be very important. So I still am a strong proponent for using all the possible 3 ways of identifying people: who they are, what they know, and what they have. You can't have one. You have to have all the options available. Thank you.
Thank you, George. So I think what's important from this conversation is hopefully the group that will discuss client registry will take all this into consideration. Of course, there are key technology issues, but I think we are acknowledging and appreciating that there are lots of non-technology issues we need to discuss openly. There are a lot of sensitivities around identifying people. We're in an era where people decide what they are, and it's a human right, isn't it? Yeah, no matter how we look at it, right? Health is a human right, isn't it? So we're getting that era, and the one thing that will be very contentious is when people can be identified. That's why it starts to get really, really sensitive. So I think the group that will get into client registry, please be thorough, discuss all these things very openly. As Dr. Amisha mentioned earlier, the Data Protection Act classifies personally identifiable information as sensitive data, and there's all legal issues around that. But again, I think as we've had, there are discrimination issues and serious harm that can happen. I see a hand up there at the back. Somebody's got a, okay, we can start there and then we go there. Let's keep it short and sharp.
Okay, yeah, hope you can hear me. Yeah, my name is Davidson Kandi, working with UCSF. So yes, MPI is also something that's of interest to me. Like in the conversation around how we truly identify patients and what value it brings to also for as regards shared health records. So yes, there's a lot of benefits, and I'm looking forward to the discussion we'll have tomorrow. How systems can consume the client registries, being that it's coming in as a service in this health space. Thank you.
Thank you very much. As the mic goes around across the room to the other side, I just want to mention that for tomorrow's breakout room, George Owiso will co-lead the client registry discussion with Jeremiah Moore. So anyway, we'll get into that later on, but some people have already volunteered to co-lead the technical discussions. So I think a comment.
Thank you very much. Maybe I'm a bit of technology challenge, so that's part of my problem. But I think the issue of identifiers is purely a mindset issue. It has nothing to do with all the things that we want to do. And it's a matter of helping people to change the frame of mind. We are identified everywhere we go, and we've never had problems. We are moving to precision medicine. With precision medicine, we have to characterize you in detail to be able to know how to individualize treatment. So we cannot say we want the egg, but we don't want the chicken. And I think this is where somebody needs to take the bull by the horns and say, we are indemnifying this is the way we are going to do it, and agree to leave the country and take the liability. Because we'll go around it, we'll do nothing, the same population will blame you for not providing for them. It's the same thing that we have done in Kenya with HIV testing. In Uganda, you can walk to a shop and say, I want an HIV test. And it is normal. In Kenya, it has remained and excluded something that you require a consent. And these are all semantics of mindset. And I think it is high time we get out of that mode
We know what identification means. I can't give you what you want if I don't know you. I think the same thing. You have a right. The government has a right to provide care, but that care has to be tailored for you. So I think it is us, and I think it is the medical professionals who are the problem, not the population. Those of us who are the technocrats are the problem, not the general population. We are the ones who make these things difficult. So I think let's change mindset.
Thank you, Prof. We might agree or disagree with Prof. Identity is a state of mind. All right, I want to welcome Robert to speak about what's going on at the community health level. How many have heard of the Electronic Community Health Information System, ECHIS? Bottom up. We know, right? So as we know, the government is very keen on achieving universal healthcare through primary healthcare. I think we all understand primary healthcare and how that's defined in Kenya's formal health system. So there's a lot of emphasis to really strengthen primary healthcare as one of the quickest ways to achieve UHC. So Robert has been supporting ministry for a long time, and I'd like to welcome him to speak about the work they're doing. For those of you who don't know, in terms of digitalization, and then also comment a little bit about some of the comments that, for example, are made by Dr. Jacob have to do with quality of systems. And I think we're getting to a point where the Health Act 2017 mandates e-health as a mode of service delivery, which means that we start paying more attention to digital technologies, unlike before where we're building apps and all manner of things and rolling them out without thinking too much about them. So, Robert, as you're talking about what's going on at the community level, please talk about quality of technology and why that is important.
Thank you very much, sir. I'm glad that you've seen from the answer, perhaps it's one question you want to see the biggest number of answers. Meaning there's a good understanding of ECHIS down to all the levels. I must say this has been a very collaborative initiative. It's been an MOH-led initiative, but partners support. I want to really give credential to partners who believe that things at a very early stage. Having the study that they will be one day 100,000 community health providers around the country providing service, and I believe that actually that primary care service we provide will have a very direct positive impact in reducing the number of community services for this country. It's been a journey, as Steve has mentioned, and just to reflect back a bit and say, what are those things that make a big success? Because it's one of those that I would say, listening to the essentials that we discussed today, to converge the health exchange. I think ECHIS ticked the box and half of them in the sense that we've already come into a convergence as partners. We've already formulated one common solution out of, we also started the corporate website, Dr. Ryan, the second year, with so many partners, so many solutions. But moving into a convergence now to one solution. But there were a number of things that made this possible. First, the implementation that everyone serves very strong leadership, but also making sure that the right policies in place, whether it's community health policy, digital guidelines, and also leveraging on the bigger master plan of Ministry of ICT. That also made it very easy for us to move forward. But again, the starting point was partners who did believe in the fact that this universe is big enough for all of us. That's whereas we can look at each other in the lens of competitors, the reality is that we are collaborators together in meetings. So I think a very essential thing towards this conversation is people to accept that when universes speak, we will have a space for each other to cut into, and therefore as we get in that space, it becomes an easy way for us collectively. We restructure ourselves into ways that we were self-governed. We had some governance structures, we had a six core group, I think a number of streams also we had one six core streams deliveries, and we also had a decision level organization set up steer that then took up the decisions and also helped a bit in terms of prioritizing the areas that we felt were important in terms of finance and in terms of and then adopting the best practices. I think one of the things that we did agree as a team of researchers, partners, and Ministry of Health, we said we were going to copy with pride. We didn't have any inspiration to copy things that have been successful elsewhere. We did not reinvent it. And so we took the step and started working on any baseline that is of good practice. Whether it's an enterprise architecture framework, and we think it will work best for us, whether it's setting up the standard service level agreements for infrastructure, whether we needed to set up a way of building the content for training, for capacity building, to make it as effective and as easy for the trainers not to struggle too much how to pass the product down to the user. But also having in mind sustainability. I think that was very, very key for us to say, we know how to provide the solution today. And then we leave as partners 1 year and 2 years down the lane, then again it falls. So again, we always having conversation how we ensure that we actually capacity build this company to be able to run what is sustainable going forward. Even in terms of the choice of the product itself, because you have the option. Sometimes it's more expensive. Give you a lot more robust, a lot more exciting solution, but you must keep it local. So where are we today? ECHIS. It's one of those that's the big flagship, the plan that is now taking ownership all the way to the citizens itself, and it's going to be very exciting for us in terms of the next couple of plans. We have delivered on the key priority workflows, and this will actually joint discussion with the users to complete user-centered approach where we have CSPs, we have community health assistants, we have county representatives in terms of designing the priority workflows the solution. Whether it's maternal child care workflows, situation of the homes, that also fits in very well with the conversation we have about the digital, the identity, because as you digital homes, you also know how to use the identity of building a bigger database of a central database. So perhaps one of the biggest entry points in the situation is we've also gone a step further to answer the question of the logistics management. To say at the community level, then how do we start building an integrated logistic management system that whatever is being dispensed from high up, we can do an account all the way to the bottom. As it is today, we build it for community, but of course, the fact that they were now emphasizing on interoperability, where whatever system we have in community is making the system that we have at the higher levels, from the 2 all the way to the 4. I think that's been the biggest opportunity for us to create a proper transparency, proper accountability, which we have to correct system management. And again, I think it speaks to this conversation. If something has been done on that level of making logistic planning, how do you also make sure that the payers have priorities in the right way, in the right standards, the system that you're building, whether it's at the level 2 or we've piloted interoperability, and I must use the word interoperability because Mr. Ryan was very particular about interoperability and integration, the separation between these two. Because quite often people can continue to use it, it becomes I must say, very proud, the first interoperability test that we did the facility level, the community level was done on complete industry standards, competitive, HIS compliance, and making sure that it's easy for us to do a plug and play for any other issues to do to ECHIS. So I guess this is the thing that we also like to adopt and go for. It's make it so seamless and so simplified that once you build the interoperability there, any other additional thing that you'd like to do, like to connect to our health facilities, plans, like to connect to themselves, logistic management system, it needs to be really very standardized and very simplified. That doesn't become a heavy burden. What next for us? I think the big opportunity now is we look at scaling to the 100,000 users, and we are very positive. This is also really great for the country. Is the conversation around providing support. When you have 100,000 people providing service alongside that, how do we also have the basic being ready to support? It's also very easy to have a solution in a fair distribution of being similar to a workwear, simply because people have problems, business challenges, how people need that experience. Let's think about it also from a big infrastructure perspective as we go forward. As we discuss AI, for example, machine learning, and data science, how ready is the solution towards being adaptable to those future technologies? It's very simple. But very importantly, the capacity people to provide the service. It's that some of the mindset here, but also the actual skill that you have to do to be able to get it done. I think the question of generally the e-bill and how it speaks, I see it in a couple of lenses. First is the lens of data protection, privacy, and how do we ensure that the systems that we build they remain completely compliant. And I think Dr. Joyce mentioned well earlier that people have used the flag of data privacy and data cybersecurity as almost like a deterrent for not asking further questions beyond. I mean, if I start putting that flag here, then it's very hard to ask me further questions about this. I think it's important that we also make sure that it's a good understanding and also that we take the right principles around data privacy, data information security, to see it in a more proactive, in a more positive way, knowing that health also is covered in the law as something that we need to provide. So I think we need to put a clear borderline, but also some sort of an over-index of things that can possibly. And I think last to say, we must have ability to tell our story. And for us to tell our story, we have a lot of data. Dr. Agas mentioned that quite well. The amount of data that we have that we can use to make a beautiful, intelligent decisions that can actually make a very positive impact. Perhaps it is one of the biggest opportunities for us to drive change. If there's a way we can handle this, there's a way we can create one national visualization dashboard. Dr. Job is very passionate about creating this, but also take interest of the partners, because we also would like to conceive other things information. As we conceive this information, we'd like to use it also positively to improve further, but also we have an obligation in always funding as well as providing services. These are the metrics of success that we see. So let's see how we can cooperatively and positively all work together in terms of this organization, integration of interoperability, and basically on our hands in terms of the Thank you.
Thanks a lot, Robert. So a couple of quick things that Robert mentioned really didn't come up quite clearly. But Ministry of Health, with support from partners, including MEDIC, has established the Electronic Community Health Information System called ECHIS or ECHIS. And as Robert mentioned, the goal is to ensure that each is an application is in the hands of 100 community health promoters. That's really, really massive. 100,000, I'm sorry. That's really massive for anybody who's working at community health level. The amount of things you can do with that, I think it's really limited by imagination. So I think just to encourage everyone who is interested in that level of healthcare, from a digital perspective, please talk to Robert and MOH staff to see how we can help all of us contribute towards that initiative. Secondly, and Robert mentioned that as well, ECHIS is a toolkit. So it's not one homogeneous system at all. And so what they are supporting ministry to do, to develop an ecosystem where people can plug in. So over time, the needs are going to evolve. The ministry will need more things at that level. And the CHT, which powers ECHIS as a platform, has the capability to add a lot more things. And so that's another thing that I think we can all contribute to, so that ECHIS is a comprehensive system at the community level. So that's really important for us to note. Robert has brought up a couple of really interesting questions. Who owns health data in Kenya? Those of you who are listening to Dr. Amisha, she presented. Who owns health data in Kenya? Sorry? Everyone. Who owns health data? Ministry of Health? No? The data subject, isn't it? Can you store data outside Kenya?
Yes.
You can?
Yes, the copy.
You can or you can't? You can? We are unsure. So if you don't know, please find Dr. Amisha and she'll tell you what you can do with data. Yeah? It's very clear. The ministry has developed a health data governance framework that is predicated on the Data Protection Act. It's very clear, all these questions. And those are the things that we want to have clarity on by the time we leave this week. Robert has mentioned them. So please, let's engage and let's leave this place with the truth. Before we move to further, I'd like to request Tabitha. Your name has been mentioned, but you need to make a comment about community health and digitalization, if you don't mind. I know it's an ambush, but we'll be calling out people like that. Go ahead. 2 minutes.
Yeah, it's really an ambush. However, I'm going to add to what Robert has talked about. Yeah, we are looking forward to having 100+ community health promoters using this, but of importance is that This is the normal service delivery. The ECHIS is just an enabler to help the CHPs really do their work. Maybe what we are supposed to be looking at is the integration between now the ECHIS, now that the CHPs have collected this data from the household level. How are we seeing this data at the national level? I know we have talked about integration to the KHIS, which I am not sure we have really seen that. And I'm just imagining that that is an area that we need to really look at. Again, the issue of the devices. I don't know whether this is the direction that you wanted the conversation to go, but I'm just my observation and what I really think should be priority is now my thoughts. The issue of now the phones, the tablets, or the gadget, or whatever application that this ECHIS will be able to see it. I'm looking at, we are saying that the government is looking forward to procure 100+ gadgets. And I know we have partners working in those community, in those counties. Can we do, I don't know whether to call it mapping, and see whether we already have these resources in order for us not to say we are still waiting for the government to procure 100+. We already have these gadgets to be able to now, come on board. I think the other issue would be around commodity management. I know the government is committed to giving us or giving the CHPs the kit. They want them to be fully kitted. We all know the contents of the kit and the match, the costs. So this is an area also we need to strengthen.
Thank you very much, Sabina. Thank you. That was good recovery from an ambush. Thank you very much. I think Sabina has raised a couple of very useful questions there. So again, government is very aggressive in terms of strengthening healthcare in Kenya. And I think the Community Health Promoters Program is one that, as Tabitha has mentioned, government is procuring end-user devices, which are basically mobile devices that the CHPs are going to use. So obviously a couple of things are starting to occur in people's minds. How secure is that data in the device, isn't it? Because this will be CHPs with personally identifiable data on mobile devices, right? And Dr. Alan will comment about that shortly, about management of the devices. But the interesting questions that are starting to emerge, and those discussions are happening, and they also need to happen here as well. We'll have 100,000 CHPs with data, right? So the issues of how will government and all of us play a role in terms of ensuring those data are safe. And so as Dr. Alan is commenting about that, I'll also put Dr. Kamau on the spot, because he's involved in some work with WHO on cybersecurity and data that is about to begin. So Dr. Alan.
Thank you very much. Thank you very much, Robert. Thank you very much, Tabitha. As I can say, I'm also very passionate about ICHIS and its potential and how we can support it. And also for the directorate, the division of digital health is new. So even as it enters the sector, there is what do you do in the sector? So we have community, for example, being the lead in terms of being the user division, and then digital health is there to support with the digital health bit. So it's something we work together, and we've seen interesting work. For example, I don't know if Robert can comment on this, but one of the interesting things we see is, and I think this is part of even the training and the change management we need to see, has been complaints about there is an unease about not being able to see the data moving. For example, if ICHIS is fully interoperable with, if it's fully pushing data to KHIS, that conversation is hard to convince that it is happening, because we don't have a model of demonstrating it live as it's occurring. So there's a lot of room for this conversation all the way from up, and that's a conversation that the division is going to have. One of the challenges we found as we were doing the user acceptability tests for ICHIS in different communities was that we had siloed implementation of, this is not the first time community health workers are using a digital tool for their service delivery. They've done it for a long time. But the challenge used to be sometimes would be done in small regions, and then after the exercise would be over and their partner had completed the activity, some of the partners would take back their devices. But because we never got to a position where we came and did it at the scale of giving out 100,000 devices, there's some processes and some gaps that appear, and that's where we're having some challenges with protecting the data. And this is especially in terms of developing the mobile device management tools. This is how we've given out 100,000 devices. They have personal data. They are all the way out across the 47 counties. How are we securing that data from here? Yes, the EG system has inbuilt protection mechanisms, which is just the logic, but we still need another layer. And this is an issue which has come up as we're going to scale. And this is something that we're going to see. The more we scale, new gaps will appear. And that's why I said earlier in the day that we have to use the theory of change logic, of being continuously learning, being very fast to adapt, to be able to overcome some of these challenges. I think I can give it to Dr. Mo.
Yeah, so Dr. Mo is involved in some work with WHO that is just beginning. So the issue around data cybersecurity, privacy, and confidentiality is not unique to Kenya. WHO is just starting to develop guidelines around that. And so Dr. Mo, maybe you can very briefly share with us what's the current thinking around that, at least from the global level.
Yeah, thank you very much. I think, as has been a tradition, I think usually security is thought as the last thing after you've done the intervention. Then you start thinking, well, what have I left exposed? And I think there's been a lot of intervention in terms of digital health that even WHO has been supporting, but from the point of view where they stand, they get that cybersecurity and privacy has been forgotten, and such there's a particular effort to develop a guideline, a toolkit that will be able to help any intervention going forward to put in practice or to ensure that security and data privacy is taken care of, even as you develop the intervention that might be there, and even those ones also which are already existing. So it will be two parts. There will be the toolkit, around 15 pages, and then there will be the technical guideline that can be used by any organization that is planning to do to develop any healthcare intervention. And I think Steve also allowed me to comment on the outcome, the concern of the outcome by Dr. Can't remember her name. There's what WHO is having what called smart guidelines, and I think if those ones can be implemented, I don't know at what particular stage this will be, whatever we are developing takes care of that. I think that will also ensure the issue of quality is taken care of, or the outcome that we do expect. Thank you.
Thank you very much, Mr. Kamau. How many of you have heard about the WHO smart guidelines? I don't remember what it stands for. So if you haven't, please look up, just Google WHO smart guidelines. So it's, as Dr. Kamau has mentioned, it's the new way that WHO is encouraging what Dr. Njoki had mentioned earlier, to ensure that there is fidelity to clinical practice, right from the clinical guidelines, but in a computable guidelines manner. So it's a knowledge layer framework that starts from level 1 to level 5, with every subsequent higher level being more digitized. So essentially what it means is that if you have like guidelines for COVID or HIV or anything like that, that is being looked at as level 1. All the narratives, all the PDFs and all that. Then level 2 breaks down those into things called visual adaptation kits. And then level 3 starts computerizing those guidelines into languages that digital health can understand. So Ministry of Health is looking at that very critically as one of the standards that is going to be strongly advocated for. And there's the group tomorrow on standard interoperability. Please join that group for further work in that. But SMART guidelines is an acronym for standards-based, machine-readable, adaptable, requirements-based, and testable guidelines. Dr. Neri Nyaga there has invested quite a lot of her time in that, so you can also, then maybe you can, people can see you, and if you, do you have comments? Or we can get into that tomorrow in the groups. Okay, wonderful. So I know we are running out of time, so we'll try and wrap this up. And our last panelist is Dr. Mogi. And Dr. Mogi will comment a lot about, he's done a lot of work in building HMISs, building shared health records. He's got deep expertise in technology services, understanding of modeling data, and technology science in general, through formal training. beyond being a medical doctor. So Dr. Mogi, maybe you can speak about that and comment about your work, but also what are the strong recommendations you're passing at this preliminary stage to ministry and to all of us with regards to those aspects. Thank you.
Thank you. So I think my perspective is from really my work at Point Hospital. Others have had experience in the tech space for quite a while. Programming software since the year 2000. Then became a medical doctor, now chief information officer, where we are really implementing systems at level 6, which is really the opposite end of the spectrum from what the Robert team are doing for the community. There are unique aspects of it which will also, perhaps also inform what goes into the superhighway. And I wanted to touch on a few. One which I've already mentioned. We deal with vendors a lot. So first of all, what we did at MTLH, we implemented an ERP. Being a level 6 hospital, it's as complex as any other big hospital, only that we don't have the budget to buy a complete solution. So what we ended up doing was we adopted an open source ERP platform, and on top of it now build all platform system, build from it comes with procurement, stock management, finance, and all these things, and then building an EMR on top of it. And while building the EMR, ensure that it is complying with all these things that we mentioned here. Obviously, without an existence of a national superhighway, we are then forced to create all these aspects, our own client registry, our own terminology service, and things like that. So this architecture will actually come very in handy in ensuring that the level 6 hospitals were able to plug into it, ensure that our client registry is coming from this, ensuring that we comply and adapt to the terminology services and a lot of other things. But the aspect that is not touched by this barrier, and I would be interested to hear, is the vendor registry, because we deal with a lot of vendors, and the ministry is dealing with a lot of vendors everywhere. It would be interesting that if a vendor is blacklisted in the National Hospital, we also blacklist in MTH at the same time. Therefore, it needs to be. And remember, these vendors for hospitals supply important commodities, and therefore, we need to be able to track a batch and get this batch into this patient, and the outcome was this. So at MTH, we've been able to build that system where we can know that a certain medication was from this batch and was given to this patient, and the outcome was this. But the problem is we are not able to plug it into the national platform and ensure that perhaps more can be done. But I think a vendor registry is part of the value that should be considered for this. The guidelines is an interesting thing. What we also learned when we implemented EMR at scale, we see more than 1,500 patients. When you implement forms, which is what everybody advocates for, it's not practical. Like the patient you see in our corridor is such that you tell people these are the forms you need to fill, but throw away those forms. People just want one textbook to type their notes, because in medical school they are taught how to write history, which is in prose. So the question then is how do you adopt that to basically the reason people are adopting forms is because it has been assumed all along that machines are not good at reading text notes, and therefore we need to hold all this data. But artificial intelligence is coming in at a fast rate, and I think even in this forum, I think it needs to be given quite a considerable attention. Artificial intelligence can help us code data from the fly. It can help us make decisions. It can help us make I know that there's a lot of work in the smart guidelines, but artificial intelligence can even improve all that and ensure that as clinicians are typing notes, it starts giving suggestions on what needs to be done. It can in seconds read all the healthcare data of a patient, the lab ones, read the X-ray, and start getting information. So I think artificial intelligence is something that we need to see how it can fit into the digital superhighway. We've been able to establish telemedicine clinics in in the hospital where our patients, the stable patients who are on the chronic disease are able, from the comfort of their home, they're able to actually book shillings and pay their 300 shillings from wherever they are. They get an SMS link or either a Google Meet link or a Zoom link for a specified time to see the clinician. Then from there, then it's a matter of data being seen, and you can do other things for this patients. And I think it's not quite clear how telemedicine, I think it was mentioned, but it would be interesting to hear how that plugs in this spy. Something else that we planned is a challenge at FTRX is radiology DICOM. I don't know where that fits in. We know that we are most likely, my proposal anyway is that we need to be opinionated or not be opinionated. For example, as far as the shared health record is concerned, I think a lot of people are in agreement that perhaps 5 is the way to go. I'm not sure how much is HL7 implements the DICOM standard. We realized quite quickly as a hospital that we are spending a lot of money on films and printing film. It costs a lot in the budget. And when we eliminate it completely, we probably save hundreds of millions of shillings just on that. But then comes the biggest problem: where do you store radiology images? And when you do a CT scan on a patient in 2010, you still need to retain it for the long term, because sometimes when you do the CT scan 20 years later, you want to see whether there's been a change in its image. If you tell facilities to post these images, it's going to be a challenge. And if you want this data to be exchanged across the board, perhaps you also need to fit, a repository or DICOM into this architecture as well. Lastly is syndromic surveillance to ensure that the super highway is very useful. We want that at the level of the ministry, as all these different EMRs people are seeing patients, we want the capability that we can quickly, in a screen, tell that, at the border in Uganda, there are quite a number of patients who are coming in with fevers and also reporting calls. Therefore, you can quickly start interventions at the ministry level before even the people on the ground, for example, here like these days. So the architecture that should be proposed is one where we need to be sending this data in real time to the shared health record, or at least in a manner that allows things like syndromic surveillance to be possible.
Thank you very much, Dr. Mogi. So a quick summary of Dr. Mogi's presentation. He spoke about artificial intelligence, and I think earlier on, Momo mentioned that there are people who have expressed interest to have a track on artificial intelligence. How many people here are interested in that as a track? I know it wasn't part of the suggested list. All right, so we'll create a track. Who wants to be the group lead? Technical group lead for that one.
It is implied that one of the tracks is under health information integrity.
Yes, so it's implied it's subsumed as one of the tracks, but people want it to be independent, isn't it? Who is so passionate he wants to be the technical lead for us? Mercy wants to be the group lead. So Mercy, just stand up. We'll make announcements later. But we want the groups to have the most passionate people in that subject area, so that we can actually advise the ministry and the ecosystem properly about that topic. I know the people who are currently doing a study on LLMs, large language models in Kenya, comparing, for example, ChatGPT and BARD and others. So I think it will be an interesting group to hear what they come up with and what recommendations they make to the ministry, and whether they are suggesting that AI needs to be part of the superhighway and where. So please think really thoroughly about what you're discussing and suggest to the ministry, so that we know where that fits. I think in the interest of time, it's 4:20. I know we plan to finish this program by 5. We can give our panelists a round of applause. And I just thought we can manage time really well, the remaining couple of minutes. There was a session on the Convergence workshop. I don't think we need to have a presentation. I can talk about that in 5 minutes. Then I'll hand over to Dr. Ryan as we wrap up. That's okay, Dr. Ryan. Yeah, so I think some of you have seen the term convergence workshop, convergence used a lot. So if you're interested in this sort of methodologies, you can Google convergence workshop. It's a framework that was developed by Asian Development Bank, and it's been used in development sector for this kind of work. It's deliberately used by the ministry for this particular gathering because there are very specific things that the ministry intends to achieve. So whereas some of them are not new to us, but they make it deliberate so that from a methods perspective, as Dr. Job mentioned earlier, ministry is very keen to have, at the end of this week, as Dr. Lagat has mentioned, we need to have the requirements specifications. That's one. So we're looking for outputs from every group, and there's a team that will be working day and night to keep collecting those and presenting them in the morning as we do the debriefs. So that by the end of this week, we have a fairly decent specification, probably high level. I don't think we can go very deep in 1 week. But that's the reason why the ministry decided to deliberately use this convergence workshop approach. So if you're interested in methodologies, look it up. There's plenty of literature about it. But it allows this process to be very logical from a moment where ministry developed the vision as it is, and then expressed interest and invited people to work with the ministry to co-create this. And then that's what we're going to do the whole of this week. Then update the vision, and then after that, implement. So this methodology and framework allows us to do exactly what Dr. Amat mentioned earlier, and Dr. Joe Brand and Dr. Amish as well. So that's in a nutshell what the convergence workshop is in 2 minutes. Like was mentioned earlier, tomorrow I think most of you have seen the program. Tomorrow we're going to start getting to the real work. So very few sessions, this kind of sessions tomorrow. Today was really ministry articulating the vision. And I guess the question is, and maybe I'll leave that to Dr. Ryan and Dr. Job to manage, but do we feel like we understand the ministry's vision? We may not agree with it, but do we understand what it is? Who is completely lost? Because I think then the ministry still has work to do. Who completely feels that, okay, I don't know what has happened today? Who feels a little bit clear that you understand where the ministry is proposing we go? Let's not be afraid. If you don't, you don't, because it means there's more to be done. So the whole idea is, again, if you go to your notes and you say in the concept notes, was the ministry was going to, and that's what the ministry has been talking about today, was to ensure that there is no ambiguity about the vision. Then from tomorrow to Thursday, it will be for, now it's your chance to completely challenge this vision, but more importantly, beyond challenging, propose. So challenging is not enough. I know we're very smart here, and it's always easy to challenge things that you haven't developed. But more importantly, make suggestions that are better than what is here. And then argue. On Thursday, we'll argue. So every group will be presenting here on Thursday why you think this thing needs to be resolved completely. Yeah? Why you think that the suggestion to use fire, to use smart guidelines and all that, not going to work. We've already been in part of conversations going on where people are saying this will take 10 years to do. Dr. Langata said it's not going to happen. It needs to be done in 1 year or less. So we need to be real about all those things, because on Friday, when the ministry is going to re-articulate this vision with all our inputs, it needs to be collective commitment. So tomorrow to Thursday, it's really our time to critique this, but most importantly, please, as you critique, provide suggestions that you believe if the ministry enables this to happen, we can all achieve this together. Because this is not a ministry vision only, it's a Kenya vision for healthcare. So that's the idea between tomorrow and Friday, and Thursday, sorry. And then on Friday, the ministry will have that report done, at least preliminary reports, and the ministry will stand here and tell us what we have agreed to do collectively, and then that's what's going to be implemented. So it's really important for us to make sure we're here tomorrow. If you feel like the people in the organization who are not here and they need to be here, given the tone of tomorrow to Friday, please invite them to come. Because then, as Dr. Langat mentioned, whatever we commit here on Friday, we are going with it. So come Haruko, or start saying, oh, you know, we didn't have a right person at the workshop, it's going to be too late. So that's all I can request. We have for the ministry, and the ministry will emphasize that. So I think tomorrow morning we'll be informed about the breakouts. We've got a couple of people who've been mentioned. If I call your name, please stay behind so we can have some discussions to plan for tomorrow. So Jeremiah Numo, Diana Kamar, Sophia Karanja, Dr. Nyoto, Dr. Wesley, Gilbert, Nancy, Yamayo, Dixon, Dr. Amisha, Helen and Jane Otoko. Then we've got George Owiso, Gitahi, Dr. Mogi, Margaret Ndisha, Rafael Kundo, Dr. Ngure, Robert Mutai, Dr. Nzisa, Dr. Kamau, Dr. Kahonge, Dr. Ramona, Dr. Sylvia, Timothy Luti. So let me hand over to Dr. Ryan to help us as we close now. Thank you very much. Thank you very much, Steve, and to all the panelists, thank you very much. That was a very, very good session. How are you feeling at the end of the first day? Are we tired? Can we continue for another hour? I won't say much, and my director is here, so he'll close the session for us. Mine at the end, and maybe I don't know if Joe has something to say. Okay. So we'll go, I'll give it to Joe and Joyce. Mine is just to say thank you very much for your participation. I hope that the main aim of today was to bring us together, acknowledge that we are coming from different areas, focus on the fact that the local capacity is here, it is local, it is here with us. This is digital health. This is our spectre. This is our thing. A lot of this work has been developed by the support of every single partner here. This is not new work. This is a reconstruction of the Kenya Health Enterprise Architecture of 2022. And this is just a model we're trying to see, is this the best way for us to go towards its implementation? So the fact that we're here and the fact that I hope today, by the end of the day, the main aim of today was to remove us from silos and to bring us into this conversation of we are together on this journey, and it is a doable journey, and it is achievable. So I won't say much beyond that. I'll just ask Job to come to finish off and give it to Dr. Langan.
Thank you, Ryan and the team. Mine is just so the discussions that we're going to have from tomorrow are going to be, technical discussions, and you're not limited, or your organization is not limited to a single thematic session. So if you have multiple interests or you have multiple people that you feel like can contribute to the other sessions, if it's, elephants and they feel like they can go to many sessions, you can contribute to as many sessions as you feel like you have enough manpower for. And if there are people who are not here and you feel like they can help in the technical discussion, kindly invite them. We still have space. Thank you. At this point, I'd like to invite our director to close out for the day. Thanks.
You guys, you're making look like this at all. Function. You have to open and close. But I'm happy to probably just give some few remarks. And I like this 4:30. I can see the faces are still very bright, so I think an interesting cohort. The tech people, I work with someone like Indisha for how long, Indisha? That is when we are developing the department's information system. And I'm still learning how to relate to the tech people. The day we struggled with my team when putting this one the way it is. I remember Choka and Ryan was saying, but we already have an enterprise architecture. And I was telling them, some of these things is about communicating. The person making the decision may not understand your language, but are you able to put it in a manner that speaks to them and they can relate? So whatever we have here, we have actually presented to lay people, and they seem to appreciate that is communicating something. They are able to see where they can come in, they are able to see why they need to put resources there. So we encourage you, it's an open space. Trust me, you're a partner, and you tell me your director report you're putting it does not make sense. I'm not going to tell you tomorrow we don't want to work with you. In this space, we need your critiquing and the hard questions. So let's assist each other. It's an open space. It's a very vibrant team. So I'm actually happy to with these division heads. Of course, Joyce is the moderating phase. Yeah, which and I like that she realized that it's a question of we have collected all this, what does it mean to us? So I know there was a question about accessing the NHTT. Probably just tell us what you want to do. We need to understand. If I give it for Nuki, when I came in, I asked the question who is managing this. And I've asked the team that we need to sit down and have a committee to do that. The framework that they developed in my office is our own carton of documents. Then I asked these guys, like, as you are going to remove less than 10, was it going to stay in this office? So let's work and make sure that those copies are available. We're still printing a lot of papers, we are digital. So can we also make sure that it's available in digital format? Because sometimes we reach something else and that's a failure. So we'll tell us the framework on how to do this and we'll operationalize it. Is what we agree is what we are going to make it work. So the NOPI documents will be here. NHTT, you are the people to tell us that you want to do it. And then those rules, trust me, if you are given a rule, I always keep it and I'm always sure that is executed. So that is the commitment for my directorate. Yeah, there are a lot of partners who have supported us in bringing this workshop to where it is at the moment. And really, of course, the most important thing is the people like this. The fact that you have sacrificed your time and you are here, we really appreciate you and thank you very much. I've got my two Master of Ceremonies, Wesley and Jeremiah. I hope Jeremiah, you told them you have the most difficult position of managing the HIE. Was it mentioned? Yeah. So he's the one that's the. Again, the vision for us is to create a national agency or authority to manage this. I don't know whether that was mentioned. Yeah, so we want to, I don't think in the Ministry of Health, we are there to support regulations, standards, and whatnot. But all our service is a business we have to give to an agency or an authority. So we are already having those conversations and how can we take that? So Momo, you will start converting yourself to be an agency, Wesley. Thank you. We also try to do ourselves. So it's restructuring, so it's going to deal with the MLs. And there are many other guys in the unit who do that. And for my division heads, in my absence, yeah, I think you have done a good job. And I also want to give maybe, yeah, there's a visitor may come in that we may disappear with this future domain. Because it's one of the countries that have a mature HIE is Korea. There's a last minute in such benchmarking to us, so probably maybe until Wednesday. So I also wanted to give that we are not leaving you is because things get planned and it will be a disappointment and unfair to you to change a meeting that has been planned for many days just because 3 people are not here. You know that is not sustainable, isn't it? That if the division knows that the director is not at the meeting cannot take place. So in case it materializes and we are not around for Wednesday, I know that we have got able leadership for Joyce and the partners like Wanye, Mumo, and Wesley. We don't need Joe and we don't need Ryan and myself to be here to make the workshop. So I just wanted to tell you that is we are still trying to get it to that visit to. So it's a CS visiting a delegation. Yeah, I think partners who have supported us, USIT, the exam LIT, DEFA generally. Yeah, and yeah, so we really want to appreciate that support. And I like this. I think the promise for even for digital, I give what I my guys, my problem is not the technology, is managing the interest and the politics. So I'm not a tech person, so I'm here to see how we can, because it's very difficult. I can tell you the people have come to all this promising to support this is very lot. But how do we make sure that each and everyone feels appreciated and there's a space? without necessarily also pushing others. I remember when we were pushing for eaches at some point, we felt like the people who believed in eaches when we didn't have the money or going out or being kicked out. So we'll also try to do that. Maybe because I may not speak, if at all we disappear to that trip, that your contribution will be valued. There will be a record that we start with this meeting and we develop this requirement. So we're going to do at the first page, the letter of knowledge. Personally, I always say we are knowledge institutions as the first thing. The list of contributors will always be at the back and that will be documented. So we are hopeful that we make sure that we capture your contribution. Yeah, because you're sitting here for 5 days. That is a salary, it's a time you spend, but we know that you are committing because it is for public good. So we try to balance those and see how we can support each other. But we also don't want to be in a space where offenders are controlling us and selling us technologies that really get us into a space where we commit a country for many years, something that we don't think is good works. So I encourage you as you contribute, just give us the best of the requirements. When we move to the next level, we also commit that we adhere to those requirements. Because at the end of the day, we are serving the public. The decision we are making today, this country will run with this HIV for the next several years. Yeah. So it's really a privilege and it's a responsibility that we are calling on you to support us. Otherwise, with that, can I wish you all the best and have a good night and bless you tomorrow. Please, the working session, be available. It's an open space. I want to repeat that. Yeah, it's an open space. You tell us what you feel. Yeah. And sometimes you don't have to agree. That's like even telling people is the most important thing is that we have listened to each other. And we agree to disagree. But at the end of the day, we take a position that is either the right decision. Sometimes it's not necessarily the most popular, but we're happy to listen to each other. And so that is the spirit of faith. And nobody will take that against you. I like the idea, the question of the offenders. Yeah, we have been procuring and some of the donors already. I've never seen you blacklisting an offender. Even yeah, even when they don't perform the terms. So sometimes you ask us, even when you did not pay them, we don't also blacklist. We don't agree to it, but yeah, we are happy to look at some of those suggestions. Sometimes it focus on legal issues. I think I was speaking to a case from one university, but tell us, I think we never talk about the offender listing. Maybe the best we can do, of course, is the offender listing. Some of these things can be enforced through peer-to-peer communication, but at least we have that list. And I like that suggestion. So we'll also listen to some of these offenders exist in the procurement nature and whatnot. And I just try to point out that as we do some of these things also, we also need to look at it. Yeah, it's your best we can navigate. But otherwise, thank you and enjoy your evening and see you tomorrow.
Yeah, apologies, we don't want to see you tomorrow. It's bad to keep you waiting a bit. Kindly, we just remaining one thing. I would like to wish you could get someone to pray. And then, according to the standards to the meeting, I think now we are now familiarizing ourselves with standards. There need to be a photo. I think most of you are familiar with that. That the funders always require at least a picture to show the individuals who are in the meeting. It's part of the standards for reporting. So kindly we will get someone to volunteer to pray. Then I'll request the rest to sit here, the rest we can stand and have a photo. I think the guys in very good suits. Consider with the cameras, they are already practicing. Someone to pray for us. Nancy, can I pray? Nancy, my colleague, can you pray for us so that people will hear your voice?
Thank you. Let's all believe and pray. Father, in the name of Jesus, we come before you this evening. We thank you so much for the day that has been. Indeed, we have seen your grace upon each and every one of us. Oh Lord, you know the desires that we have for this week. We pray that you may give us wisdom, knowledge, and understanding. As we separate one from another, we pray that you may keep us safe, till you give us an opportunity to come and meet tomorrow morning. For this is my prayer in Jesus' name.
Thank you, Liz. Let's have a seat and then the rest can start at the back. Kindly, if you're seated, you're keeping us, and if you're standing, you need to be moving so that we avoid traffic. I know most of you like me are trying to avoid traffic. And let's use the expressway.
I wouldn't be sad.
Hii kamera itakuchukua vizuri.
I thought you were going to say
Itakuchukua vizuri. No. Now umefocus kabisa. Sasa you're taking water directly.
Okay, please, we can meet all of us here. Let's come. From behind there, all of us. Some of us can spot in front.
Is it? I don't know.